SICS, and I begin the presentation.
Ladies and gentlemen, young and old, this may seem an unusual procedure speaking to you before the presentation begins. But we have an unusual subject. The story of freedom. Ladies and gentlemen, young and old, this may seem an unusual procedure speaking to you before the presentation begins. But we have an unusual subject. The story of freedom. The story of freedom from inadequate results and outcomes. The story of freedom from expensive equipments and their AMCs. The story about whether our surgeons will be ruled by the science's laws or whether they will be ruled by the whims of the dictators. Our surgeons are the property of the state, or are they free souls under God's grace? The same battle continues through ages and continues till today in every field. Our aim is not to create a story, but to remind you of the story being written every day for the last 300 years. The optimum outcome of a cataract surgery is not in the machine. Rather, it's in your nerves. It's about how sincerely we commit ourselves to each step of the surgery. We come across many surgeons who believe that early post-operative results of manual SICS are not as good as phacoemulsification or femtolaser-assisted cataract surgery. We bring to you the micro-focus into the basics of manual SICS. What do we do to bring out results that are optimum, customized for each patient, and consistent? Let's make each eye count, and let's give this world the best we can irrespective of what one can afford. Let's give them their right, the right to sight. Our stepwise 10 commandments to bring out optimum results in manual SICS. First is the pre-operative workup. We stress upon doing it yourself or appoint your most reliable optometrist to it. Do not leave the entire process on him. Talk to the patient and note his needs for distance, intermediate, and near vision. Do refraction yourself. Note the findings under dilatation and counsel the patient regarding the expected outcomes of the surgery and write it on a paper. This is going to help you in later planning during the surgery. Do not give unrealistic expectations to the patient. Do not give a blanket therapy of topical anesthesia to all the patients. Counsel them for their individual personalities. Aim to make the patient comfortable during the surgery. Our aim is the safety of the eye. Choose the anesthesia in which you are comfortable and expect to deliver the best result. Conjunctival incision should be very meticulous and clean. Protect the sclera as well as buttonholing. Leave a frill of conjunctiva along the limbus. This protects the limbal stem cells and limbal vasculature. The healing is faster and gives the patient lesser foreign body sensation than clear corneal wounds of phacoemulsification. Cauteries only the blood vessels. Measure all your incisions. Scleral incision should be of adequate depth. The blade used should not be blunt. Hold your breath for a clean incision in one go. Ragged incisions lead to more fibrosis, and SIA Blumenthal side cuts help increase the incision size without adding to astigmatism. A self-sealing sclerocorneal tunnel is the heart of your surgery. Stabilize the globe well. Clear off any debris in your field. Make a scleral pocket first and then enter the cornea respecting the curvatures of the globe. Crescent blade should be sharp for a clean dissection. Remain in one plane through the span of the tunnel. A tunnel that is deep at one point and superficial at the other might not seal well and give SIA surprise later. Side port to fashion araxis should be at least 90 degrees away from the tunnel to aid in removal of subincisional cortex in later steps. Stain the capsule and fill the chamber with visco to negate the intralenticular pressure. The key here is that we have to make the capsule flat to keep the rhexis in our control. Overfilling of the chamber leads to concavity of the capsule and increased risk of rhexis running out. Similarly, a loose chamber poses threat to the rhexis. Size your rhexis according to the size of the nucleus anticipated. If the nucleus is too large, one may go for an oval rhexis. An inadequate rhexis is a threat to zonule at the time of nucleus prolapse. Centration of the rhexis should be good. Follow the Purkinje images on the cornea and lens surface to center the rhexis and not the pupillary margin. The lens is going to centrate itself in the bag and not the center of the pupil or cornea. Corneal valve should be very cleanly made with a sharp keratome. Remove some amount of visco from the chamber to decrease the pressure above the nucleus, then go under the anterior capsule. Tend up the capsule and with a bold but gentle blow do a cortical cleaving hydrodissection. Tap the nucleus on the opposite side to release the fluid and prevent a blowout. If your hydro is complete, this will bring out one pole of the nucleus. Now, shift to visco cannula. Inject some visco beneath the prolapsed pole to protect the PC. With the same cannula, gently cartwheel out the nucleus along with visco injection to protect the iris, endothelium, and PC at the same time. In this case I bisected the nucleus with 2 instruments and delivered with irrigating vecties. Visco expression is a safe option for beginners. At all the times, AC should not collapse. Complete cortical wash is very essential to achieve IOL centration, limit reaction, prevent corneal edema and post-operative rise in IOP with gentle sweeping movements. Go under the anterior cortical fibers, catch hold, and bring the chunk to the center in iris plane and slowly aspirate it. If you feel resistance, do not pull, you have caught the capsule. The chamber should not be let to collapse. Do not press the posterior lip of the wound. Side port should be used to maximum for aspiration except the sub-side port cortex. Gently flush the cortical debris from the endothelium too. Good IOL implantation is the reason for the entire story. Inflate the bag well with visco. Space should be created between anterior capsule and PC to facilitate leading haptic to fall in the bag. In foldable IOL, with visco only, the trailing haptic can be pushed inside the bag, eliminating the need of extra instrumentation. Both the haptics should lie in the bag for good centration and desired effective lens position on which depends the final refraction. Wash every bit of visco from the chamber to prevent raised IOP post-operatively. Visco is also toxic to the endothelium and can lead to corneal edema. Gentle tapping and rotating the IOL with Simcoes brings out the visco from behind the IOL. If you start seeing stretch marks on PC, it means it is clear off the visco. Hydrate the side port well to make the chamber watertight. Now, a neglected but very important step is tenons and conjunctival reposition. A good refractive outcome can be ruined by simple foreign body sensation in post-op period. Remember, we left a frill of conjunctiva during initial conjunctival incision. Note now how well it closes on itself. After the surgery, make a point to meet the relatives and the patient personally. See the post-operative care yourself. Do refraction at every visit and counsel the patient about the benefits of the refractive outcome attained. Because in the end what matters is not a blanket therapy of zero refraction for all. Some patients will find a myopic astigmatism or monovision a better outcome, if counseled well. Try to customize and make your patient spectacle free for majority of the activities. In the end what matters is a smile that patient gives to you.
Ranjit.
ना आवाज क्यों नहीं why blood was shown in the AC after the
video has narration of my voice, so let us listen. Very happy to be here, and such a great hospitality and such beautiful arrangement. Uh, Congratulations to the organizing team, and my deep respect to all my colleagues. This video is for my dear ophthalmology residents all over the world. Let us learn SICS. The draping should be such that the eyelashes are covered nicely. Then apply a speculum. And now the ocular surface is thoroughly cleaned, applying some drops of povidone iodine. This is a very important step. The ocular surface has been prepared in the preparation room. A few drops of povidone iodine has been applied, and it has been kept for 5 minutes. And now watch this. This is superior rectus bridle suture. The eyeball was turned down using a muscle hook. The superior rectus bridle suture is applied, and this will stabilize the eyeball and making the sclerocorneal tunnel will be easy if we put this superior rectus bridle suture. This is particularly necessary for the beginner surgeons. Experienced surgeons can do anything. And this is peritomy. Peritomy is being done for about 2.5 clock hours, so that we expose an area of about 8 millimeter. See the cataract. It's a brown cataract, nuclear sclerosis about grade 5, and this is an ideal case for SICS. We can do phaco in such cases. I can do phaco with my submarine chop technique, but there are thousands of ophthalmologists around the world who will find it safer to do SICS in such cases. So, SICS is being shown in this case. One more reason to do SICS is that I want to teach SICS to my dear ophthalmology residents all over the world. This is a very nice technique. You must learn this. Even if you are a phaco surgeon, you must learn SICS, because in some cases you have to do a sclerocorneal tunnel and remove the cataract or the pieces of nucleus through the sclerocorneal tunnel, particularly when there is a rhexis runout or there is a posterior capsular rent with a lot of lens matter remaining in the capsular bag. And now this is the incision on the sclera. This should be about 300 micron thickness and 300 to 350 micron. There are guarded knives available with Apasami Associates. You can use that. Otherwise, there is no other way to show how deep to go. You have to teach yourself how much will be the force on the sclera to get an adequate depth of this initial incision. Once this incision is made, then sclerocorneal tunnel is started. We must do the sclerocorneal tunnel in such a way that the inner opening is about 2 millimeter more than the opening on the sclera. That is, the opening in the cornea is more than the opening in the sclera. This helps in engagement of the nucleus in the sclerocorneal tunnel. And when we do the dissection to make sclerocorneal tunnel on the sides, we have to follow the contour of the eyeball. Otherwise, we may just cut the scleral flap. This is a sight port on the right side of the main incision at about 9 o'clock or 8:45 o'clock. An air bubble is injected to fill up the anterior chamber. Trypan blue dye is then applied over the ocular surface. And then this is a bit of adrenaline, and then the dye is washed out. This is a 23 gauge Simcoe cannula. And now the anterior chamber is filled up with viscoelastic substance. This is 2% hydroxypropyl methyl cellulose. And now the sclerocorneal tunnel will be opened. Keratome is taken. It goes to the anterior extreme of the tunnel. That means it goes into the cornea till the tunnel is made. Anterior extreme of the tunnel, and then it is, goes downward, and then we cut with forward movements only. Engage the keratome at on site, and just by forward movement you cut it. If you just cut in both ways, going forward and coming backward, then there can be leakage or chance of leakage of fluid through the main wound is more than when you make a single plane. And now I am going to do the capsulorhexis with this cystitome, a 26 gauge bent needle. Since the cataract is hard, the nucleus is huge, the rhexis should be large. The size of the rhexis should be 5.75 to 6 millimeter, so that the nucleus can prolapse into the anterior chamber easily. And now I am using the utrata forceps to complete the rhexis. Almost half of it was done by the cystitome and the rest by the utrata forceps. And we have got an adequate sized rhexis. Now hydrodissection. 27 gauge needle and BSS. The fluid is injected in small amounts at multiple points, and I'm sure that the fluid, hydrodissection has been done, but there are some capsulocortical adhesions. To break that, I'm going to do bimanual rotation of the nucleus in this case. And now to bimanually rotate the nucleus, a small side port is being made on the left side of the main incision. And now a Sinskey hook is taken in the left hand and another one in the right hand, and the nucleus is rotated. And then the two instruments goes through the main wound, and then by rotation the nucleus is prolapsed out of the capsular bag and it is placed over the iris, that is in the anterior chamber. And now we have to protect the corneal endothelium nicely, so visco is injected both in front and then behind the nuclear mass. In this case I am going to use an irrigating vectis. Here it is. See how beautifully we can, this is the trick. Very easily we can we can deliver the nucleus, provided the wound is adequate. And now after the nucleus has been delivered, we have to clean the cortex. At this time I take a 23G Simcoe cannula and flush some BSS, that is balanced salt solution, towards the cornea, so that the cornea becomes clear. Whatever cortical matter adheres to the cornea is dislodged, and we get a better visibility. Visibility becomes much better. And now there is some cortex at around 8 o'clock. We have to go through the main wound, and for that some visco should be injected and the antechamber should be filled up with visco, because then only we get some time to clean this cortex. The chamber doesn't collapse suddenly if the anterior chamber is filled up with visco. Now, going through the side port, I removed some ticks from 1 o'clock and 2 o'clock. And now is the time to implant the lens. The anterior chamber and the capsular bag is filled up with 2% hydroxypropyl methyl cellulose. And in this case, I'm going to implant a PMMA lens with a 6 millimeter optic head goes. The leading haptic goes in the capsular bag, and the trailing haptic is also placed in the capsular bag by McPherson's forceps. See the wound. The wound is nicely apposed, and when the wound is nicely apposed and when there is no gaping of the wound, astigmatism is very minimal. It is within on diopter, maybe 0.75 or 0.5 diopter of induced astigmatism, if there is. So after that, we just clean the visco and conclude the case. Thank you very much.
Thank you, sir, for such an elaborate insight into this surgery. It was a treasure trove for our budding ophthalmologists. Hard brown cataract. It is a surgery which strikes waves of apprehension even in skilled and experienced minds. We are forever eager for expert guidance in extraction of this perilous brown pearl. I now invite on stage Dr. Karamjeet Singh, sir, for his talk on tackling this beast.
Dear moderator, please ask speakers to stick to time, otherwise we won't be able to finish this.
Very good morning, respected chairpersons and my dear friends. Actually, my talk is basically on hard brown cataract, and it is so hard brown cataracts, or basically age-related brown nuclear cataracts. It is more frequently seen in Indian population because of excessive exposure to UV light, and also there are so many invalid reasons for postponing the surgery. Especially we find in very old persons these type of cataracts, and also inadequate access to healthcare, especially of Punjab and surrounding J&K. So operating on dense brown cataract, which are often associated with pseudo-exfoliation syndrome, complicated cataracts following uveitis, and traumatic cataracts. Basically, this is really a surgical challenge for even experienced surgeons. Due to the common complications in brown cataract, like zonular weakness is there, then endothelial damage because of excessive manipulation in brown cataracts, and of course the high risk of posterior capsular rent. The goal of successful cataract surgery in dense brown cataract is to remove the lens while minimizing the endothelial cell damage, avoiding the wound burn as in we see in phacoemulsification, and to overcome the intraoperative complications and also to minimize the post-op inflammations in brown cataracts. So my preferred technique in hard brown cataract is basically manual small incision cataract surgery. Although I can do phacoemulsification in these type of cataracts, but I find that post-op complications, intraoperative as well as post-operative complications are more in manual, in phacoemulsification as compared to manual small incision cataract surgery. So I'm straightway going to, this is a 94-year-old male which is referred to our department from a tertiary, from a village. And I prefer to do manual small incision cataract surgery in this. After making good conjunctival flap, so my incision in this is, I planned a little bit larger incision. It is, the outer is approximately 7 mm. And the tunnel as usual. Then after that I prefer to do capsular access through side port as Sir Mahanta has shown. Good. So I usually do large capsular access because the size of the nucleus is big. It is bigger in size. I used to do approximately 5.5 to 6 mm capsular access to easily prolapse the nucleus inside the anterior chamber from the capsular bag. So from the side port it is very easy to do capsular access, large capsular access. I mostly do from the side port only. So this size of capsular access is sufficient to prolapse the nucleus into the anterior chamber. After that I complete my incision with 2.8 keratome. The inner incision should be approximately 2 mm larger than the outer incision on both sides, so that there is easy manipulation of the nucleus. A gentle hydrodissection in this as the capsule is weak. After that, gentle nucleus rotation. We can do bimanual rotation also. And during rotation, the nucleus is prolapsed into the anterior chamber. And with a little rotation, it is free from the capsular bag. So I prefer to do visco expression in my most of the cases. So I find that visco expression is least traumatic to the endothelium, and we can easily prolapse this type of hard brown nucleus. See the hardness, and it is brown nucleus which is over there. And after that, of course, the removal of the remaining cortical matter with the 23 gauge Simcoe cannula. So we can easily wash out the remaining cortical matter. So as the sir said that wound stability is must for attaining post-op, good post-op results. So see, and also I am implanting 6 mm PMMA lens. So this is, so in the bag lens to this 94-year-old male. So now, so cataract surgeon must master MSICS procedures to handle such type of challenging cases, as these type of cases are little bit difficult to manage with the routine phacoemulsification even by the experienced surgeons. Thank you very much for your patience. Thank you, sir.
Nice surgery, Dr. Karamjit. I just want to add one or two things. Your incision size is really good, but we can reduce it by giving 2 back cuts on the sides and with scleral pockets. This 7 or 7.5 mm can reduce to 6 mm with same results?
Sir, actually I decide my incision according to the nucleus. When nucleus is hard, brown, rigid, so my incision is approximately 7 mm. Otherwise, I can do in 2 mm also, but
No, no, that's not the point. I don't want to divide the nucleus.
yes.
In this case, you attempted visco expression very nicely. That same visco expression can be given 6 millimeter with back cuts and scleral pockets.
Yes, sir.
Things will be
Yes,
changed
sir.
with that.
Yes, sir.
As far as my experience is concerned.
Yes.
Yes.
Thank you, sir.
Thank you, sir, for these wonderful tips and tricks. Surgery happens in our minds, which we train with practice, seeking comfort in familiarity. Hence, even a small change like a new site for surgery often feels like a formidable task. Or, is this change truly swarming with challenges? I invite Dr. Shakeen Singh, sir, to kindly enlighten us.
Before Dr. Professor Sakin Singh starts, I want to add to those people who are doing excellent phacosurgeons, and I want them, they have to form a group of master cataract surgeons so that they master SICS and phaco both, so that the younger people look up to be there. And a hierarchy has to be made, and I am also thinking that those who are doing cataract surgery and glaucoma or other surgeries, so there should be a class of people who are pan-ophthalmologists, and that club should be formed. Because then the younger generation should aspire to be there. Now suppose a veteran phaco surgeon is there and somebody starting, he is also doing the phaco, how the audience is going to distinguish these people? Because he is beginning and somebody is ending his career, both are phaco surgeons. So I think if you are going to really take the surgical skill to the next level, this group has to be formed. Let's see who can harness this cat. Thank you.
Good morning, everybody. So I must thank Dr. Rajendra once again and the institution Adesh for giving this opportunity to stand before you. And I really appreciate the beautiful preparation for this conference, which seems to be an international kind of a presentation, though it's in a state of Punjab as a regional. The topic given to me is the temporal small incision cataract surgery. And before I start my presentation, I would say this, my aim towards small incision is to make it simpler, easy, and cheap on the part of the surgeon to go ahead. I don't want many instruments to be used for my surgery. It would be very easy for the beginner to learn and to execute that surgery in a simpler way. Second thing I would want to share here, this small incision cataract surgery is definitely like we have a bread and butter or cataract, and this is a bread and butter for the eye surgeons. We need to know this in the beginning, and temporal incision cataract surgery, I believe, is a need of a very expert phaco surgeon also, because when he has to, he's in a soup and in a trouble, he can easily go along with the successful surgery. And for the beginners, while doing temporal incision cataract surgery, they can easily shift on to phacoemulsification, which is the, you can say, a fashion nowadays. Though the machines, they are not very expensive, and it's most of the patients, they want a stitchless surgery. They would call Sanu Tusi ji laser surgery. Maybe the small incision is going to give us a better or maybe not bad kind of outcomes, but patient need has to be fulfilled. To me, if a patient has come for phaco, I would do phaco surgery. Maybe the cataract is a brown, black. But for other patients, like in my camp surgery, I usually do, when we need a bulk surgery, you need to shift on to small incision cataract surgery. So not wasting your time. Temporal small incision cataract surgery, there's a lot of work has been done on clear corneal incision. That was my topic. From last 20 years, I'm doing only temporal incision cataract surgery. And there are a lot of papers which has been published towards this clear corneal incision and cataract, that may be in phaco, towards surgical induced astigmatism after cataract phacoemulsification, clear corneal incision of 2.75 mm for cataract surgery, superior versus temporal incision, enlargement of temporal clear corneal incision, treatment, treating pre-existing astigmatism. So are the paper by Radhavan. And if you see, they have a edge over that superior, so is the other paper. They say that temporal incision is comparatively better and you can monitor astigmatism better than superior incision. So few of my surgical video I would share here. Most of my steps are, you would see, is the similar. I do not want to raise the conjunctiva. You have to cauterize. You are sometime really fed up with a conjunctival bleed or something like that. I don't want to incise the sclera. It's going to give you subscleral inflammation later on. So just 2.8 entry, capsulotomy or orexis, and this is 20 gauze cannula, which is going to hydrate, hydrodissection, and simultaneously prolapse the nucleus in the anterior chamber. And I use a irrigating vectus, which is going to bring that nucleus out, and the crush is done in the tunnel that would not damage the endothelium next day. And with the, I use reverse Simcoe. You might have noticed yesterday I was fiddling with the Simcoe routine, which was, I never used it. So I use the reverse Simcoe. And Dr. Karmajit was inquiring about subincisional evacuation of this cortex, and you can see it's easily being cleared. That's how you go to subincisional issues. Every time steps would be the same. Of course, we need to be very careful before start of the surgery. You wash the conjunctival cul-de-sac with 5% betadine and a drop in the preoperative area. That's done for all my cataract surgeries. Half an hour, one drop, and 5 minutes before the patient is taken to the OT has to be given a 1 eye drop, betadine, povidone, iodine solution. Those are the direction from our AIUS guidelines also to prevent the endophthalmitis. I don't use any Sinski rotator or something like that for the nucleus delivery or rotation. I simply go with a 20 gauge cannula with the fluid on. Fluid is going to subluxate, going to make a hydrodissection, separate the nucleus from the subcapsular underneath posterior capsule, or maybe assisted with the visco if it's required. Here we see subcapsular cataract and mature cataract. For my small incision, I do not prefer dye 2. So the first video is at a real time. You would see this surgery has been finished in 2 minutes 10 seconds. This is, time is not your issue. We should not be very fast, but streamline your steps, your procedure, so that you don't waste time in between, and they are executed the way you wish to. Going with the cannula, the nucleus is going to be moved up out of the bag automatically. For the beginners, as we have discussed yesterday, cane opener capsulotomy is a better, safe. Subsequently, doing 100, 200, 500 small incision, you can shift on to rhexis. So this fluid is going to push everything out. You are left only with a small part to be aspirated.
7 minutes.
Just one more. I would skip this. For the sake of interest, I would share this one of my old videos when we have been doing 4 mm, 3.5 mm small incision, manual small incision cataract surgery. Here I'm going to go with a crescent. And this surgery is through 3.5 mm, all grade of cataract. Though when I have to do a smaller incision, I would prefer a phaco. So you see, we have all grades of cataract. Steps are almost the same, only the incision is smaller. But to fragment the nucleus, I would use the needle from exactly opposite or from the side to bisect, trisect or quadrisect the nucleus, depends upon its hardness. The 26 gauge needle is bent onto the sideways, so that it's going to help as a knife to cut the nucleus. While you come out with the nucleus prolapse, the cutting is automatic. It's going to be crushed. So this is the cannula which I usually use, coaxial, Dr. Dalji saying coaxial aspiration, irrigation aspiration. It's more convenient for those in the beginner to have a sub-incisional aspiration with this. So with this you can go in for foldable or other lens. So I would conclude, temporal incision for manual small incision cataract surgery is a convenient, safe, secure, easy and astigmatically safe choice, hence shall be performed by everybody. Thank you.
Thank you, Dr. Shakeen, for such an insightful talk. SICS with trabeculectomy is a dying art, and we are blessed to learn it from an accomplished and skilled surgeon like Dr. Anuradha Raj.
Dr. Shakeen Singh, can I ask one question? Ji sir. With due respect, why can opener capsulotomy in the present era?
Like with cane opener, the nucleus prolapse is easy. The rhexis would hold the nucleus tight. The delivery of the nucleus from the rhexis is slightly difficult, though you have to plan a bigger rhexis, but in that case you are compromising zonules. Secondly, aspiration of the cortex from this irregular margins, which maybe you have designed in a well-fashioned disc so that there's no extension peripherally, is again easy. Third thing I would say for the beginners, because for the beginners to learn rhexis is a tedious job. So they are really would not go in for that kind of learning which is tough. So they can start early, they can be more comfortable, they can be successful for the cataract surgery when they start with a cane opener.
Yeah, it's good for beginner, and maybe can opener is not a no-no for SICS also. But what about the long-term stability of the lens in the back? I think
I have done.
somehow we compromise.
I have not come across any complication with cane opener versus rhexis. I have never come across any surprise so far. I do understand, I do say that most of the paper they advocate rhexis is better over the cane opener. I personally have not seen anything which is better with the rhexis because I'm practicing both in all my patients. Exclusively in my phaco, I have to go in for the rhexis, and in cases of small incisions, most of the time, not seen here, this is my old videos. Nowadays what I do, I go a quarter with the cane opener, then with the utrata forceps I would do the rhexis. So to the beginner I would say the cane opener is as good as the rhexis. Once you are efficiently convenient, then you can go in for the cane, Praxis 2.
Good morning, respected chairpersons, my dear colleagues. And first of all, I would like to thank Dr. Rajvinder for giving me the opportunity. So topic of presentation is SICS combined with trabeculectomy. There are so many indications for SICS where we can combine this technique. That is Morgagnian cataract, intumescent, calcified anterior capsule, corneal opacity, unhealthy cornea, small pupil, high-grade cataract, and cataract nigra. But indications of trabeculectomy are when we are controlling the IOP with maximum therapy and patient is not responding or non-compliance. Sometimes acute attack and it is resolving, but pressure is not coming to the normal. Side effects of the drugs, of anti-glaucoma drugs, they are very much high sometimes, and we have to switch on to the trabeculectomy. Advanced glaucomatous damage, non-achieving of the target IOP, as well as progression despite best treatment. So we want to combine, then main cause is coexisting cataract as well as glaucoma, phacomorphic, pseudoexfoliation, and PSEG. So these are few conditions where we can combine, but challenges are still there. Shallow AC is one of the challenge in cases of glaucoma. Hypotony, previous tab is there and you want to do another one. Floppy iris, small pupil which is non-dilating, and challenges are synechia because such kind of patients, they have multiple attacks and inflammation which is smoldering. And preoperative consideration are visual acuity, status, slit lamp examination, anterior chamber examination to see pseudoexfoliation, glaucomatous optic atrophy, any pathology in the macula or conjunctival surface. We have to see whether we can make a good bleb over it. And grades of cataract, of course, IOP, as well as on perimetry. If macular split is there, we have to be very careful about the snuff out. So visual field parameter, VFI, to show the progression. If it is 0% perimetrically, it is blind, and PSD to show the deviation in the shape of hill of vision, and MD, which is in the minus value, mild -6, moderate 6 to 12, and severe more than -12. Various special consideration as meiotic cataract, we can do mechanical stretching. Sometimes it is irreversible and we can use the expansion devices. In cases of shallow AC, we have to save the endothelium, so sodium hyaluronate can deepen the interior chamber, as well as thorough wash is required for the interior chamber. Otherwise, it will lead to raised IOP. CCC should be adequate in size depending upon the size of the nucleus. Good hydrodissection is key to success of the surgery, and whatever the IOL you want to put can be. Type of combined surgeries, we can do SICS with IOL with trap, or phaco IOL with trap, single site or double site both. So various tunnels are there which can be combined with the, this trabeculectomy, triangular incision, straight incision, W shape, and flying eagle incision. So this is one of the case scenario with the 65 years old male with best corrected visual acuity 3/60, IOP in late 20s after 5 drugs, and glaucomatous optic atrophy, grade 3 cataract and small pupil, HCV reactive. And here we combine this surgery. Post-operative 1 month, IOP is 12 without any AGM, best corrected visual acuity 6/12 with some cylindrical. So these are few steps. All the steps are, all the eminent surgeons have shown those steps, and everybody is aware of all these steps. They are no different. But here we have to be very careful when we are making the tunnel. The center part of the tunnel should be a bit long because we want that posteriorly directed bleb in that area. All steps are same. Sometimes I do pupillary stretching a bit if nucleus doesn't come out, because nucleus, these kind of pupil, they are, some kind of ischemia is always there on the pupillary sphincter, and these pupil don't dilate despite your best effort. After putting the IOL, put some pilocarpine so that we can get best of the iris for iridectomy. Then we can make the trabeculectomy site. Incision, it can be with the help of 15-degree knife or with the help of Kelly's punch. We can take a snip of it, and then we can do iridectomy from the same site. Rest of the steps are same, but here we can we should suture the tunnel, because other day you can get hypotony, sometimes you can get flat blebs later on, so which will not be successful. So these are few post-operatives. So these are few diffusely elevated functional blebs. So total, I have done 40 cases with this data. Average age 64, IOP average before surgery 38.5, and glucomatous optic atrophy in almost all the cases, with fibrin in interior chamber in 3 cases, hypotony and hypotony as well as hypertony. Both are the complications in these cases, and hyphema also sometimes, because if it is a bit of AC shallow if gets shallow, then it can lead to sudden decompression of the anterior chamber and can lead to hyphema. So complete success was considered if IOP is less than or equal to 21 without AGM after 3 months, and partial success if we have to put patient on 1 anti-glaucoma drug along with, and post-operative IOP spikes were if first week it is more than 21 millimeter of mercury. But here we have taken the target pressure in mind, that if patient is having glucomatous optic atrophy of 0.9, we should keep the pressure in between the range of 12 to 14. So failure is persistent hypotony less than 5 millimeter of mercury, and IOP hypertony is if it is more than 21 millimeter of mercury. So on literature review, our study is going consistent with Rameshri et al., Khurana et al., and Verma et al. We have seen that average baseline IOP pre-op was like this, and after 8 weeks, 12 millimeter of mercury, we are getting it, and without anti-glaucoma drugs. So to conclude, a combined approach to cataract and glaucoma is the option of choice for the patient with the poor compliance in the difficult follow-ups. Diffuse functional blebs, they are noted as the incision is larger in size, and they are posteriorly directed. To conclude, intact anterior corneal lip is the mandatory, and it should be always intact. If it is premature, it will not be successful. Corneal suturing is must. Closure of conjunctiva should be meticulous, and post-operative hypotony is a major concern. These are my references. Thank you.
Thank you, ma'am, for this detailed surgical lesson to all of us.
There is one question. What was the condition of the AC next day? Was it shallow, too shallow, or fine?
Sir, because normally we don't suture the tunnel, but in these cases I suture the tunnel. All the cases were okay, were formed, but yes, in 1 or 2 cases hyphema was there, and even hypotony is also there, because sometimes diffusely elevated bleb are there, and 1 or 2 cases I have seen the leakage also, but after putting the bandage contact lens, that also got over.
You see, what type of, in what sort of cases you have done this trab and
so where the patient is having both entity going together, or I am seeing that patient is having visually handicapping cataract also, and pressure is also not getting control. So we want to combine the both.
Any hyphema?
Hyphema, yes.
It was there.
In 3 cases I have got out of 40. But that was just streak hyphema. In 1 case I have to remove it.
You have done very good by putting pillow carb and everything. This
Yes.
was essential to do trabeculectomy. But at the same time, what precautions you have taken, it's very good.
Thank you, sir.
I would like to add a very good presentation. Though we carry a notion amongst the cataract surgeon that doing cataract surgery would reduce some of the pressure. But what I have, gone across my own practice, all of my patients with glaucoma pre-existing with 1, 2, or 3 drugs, I would like the patient shouldn't have anti-glaucoma afterwards. So irrespective of the need of the patient with the glaucoma, I would go for combined phaco-trab. We have publications with this, with the stitchless phaco-trab also. So in my small incision, this is the only area where I would go a superior in phaco-trab or a combined trabeculectomy and small incision cataract surgery, wherein I would form 3 mm triangular incision and extension, then subsequently all those procedures. And I feel subsequently, no doubt, the scalar lip has to be sutured. In my case, we use a steel suture. It's really very good, very good closure. I have never ever come across any additional complication as we usually go across with a small incision or a routine phacosurgery. Maybe when you do a stitchless phacotrab, you find a shallow anterior chamber which subsequently would form and be easy to go. Never ever with a hyphema, we need to be definitely careful when you plan your scleral tunnel. So if you cauterize well, that would not let you to the bleed inside the anterior chamber. So I personally feel all these glaucoma patients with cataract, we should opt for phacotrab or small incision cataract surgery with trabeculectomy. Definitely these patients, trabeculectomy drainage is a definite which don't need any compliance of the patient, and patient compliance with the medication we are not very sure. So that's my take. Thank you.
Madam, any experience trap other side, not with same side?
Sorry, pardon, sir?
You did SICS
Yeah.
superiorly and Kelly's punch in same wound only. Trap at different site, same sitting. Any experience of that?
I have done one or two, not more. Because I am very much comfortable in this and I am getting very good result, and I am even publishing this data also.
Nowadays what we are doing, trap surgery is a very less, because number of drugs are available plenty and we are more than satisfied with drugs, but few cases where things are really difficult, I prefer different.
But sir,
different
here
side, because
in
that's really results are really different.
sir,
In
all
my
the
hand
40
side
cases were having glucomatous optic atrophy. Actually, where we don't touch even, we don't do trab, because snuff out chances are there. So better to do something for them. So that's why I have done it, but no snuff out till date.
I'm not talking about something, I'm talking about different trap, same sitting,
No,
site is different, that certainly
So as
your results will be better.
yeah, two
Your
sides.
results
So
will
I have done one or two, but not more.
no problem.
Thank you, sir. That's what now I'm feeling, because it is written that if there is macular split on 10-2 and you are seeing that black spots and you feel scared before going for trap. But yes, I'm doing it and it's fine. Even one-eyed patient I'm doing, it's okay. Yes, that's what I have, touch wood. Yeah. Yeah, we can take chances. Thank you.
I invite on stage Dr. Amarjeet Singh Patwalia, sir, to share latest innovations and newer advancements in manual small incision cataract surgery.
Excuse me, someone. इसमें जब फॉरवर्ड करते जाएंगे तो वीडियो अगर मैंने स्टॉप करनी है तो कहाँ से करूँ? पॉज आएगा? चलो जब वीडियो आएगी तो मेरे साथ ही रहना, हम देख लेंगे. Respected dignitaries on the dais, my dear friends and colleagues, my today's topic is about Patwalia's butter knife chopper, a new advancement in manual SICS. We have already mastered almost all the steps in manual SICS, starting from the size of the incision, the site of the incision, the shape of the incision, the depth of the incision, and even the internal corneal wound has been mastered. But still, sometimes we get surprises of astigmatism. As such, astigmatism is not a problem. The problem is with the stability, with the reproducibility. Now, what do we mean by reproducibility? If you have two patients, post-operatively, if you want the patient should remain minus 0.75, it's not possible. You don't know what is the astigmatism after 2 weeks, after 4 weeks, or after 7 weeks. So there has to be something which can control this. So my hypothesis, what it says, that scleral healing is not in our hand. The only thing we can control is we can give the incisions absolutely fine. But what about the healing part? We don't have anything, any clue about it. So why to touch the sclera? So what it says, only work with the cornea. If you just fiddle around with the cornea, and if the incision is less than 3 millimeter, I think you are going to get pretty less astigmatism. Now, why there was a need of a small incision? Because in manual SICS, the size of incision is big. So this means you can't go for ICLs, you can't go for toric lenses, you can't go for multifocal IOLs, because if you implant multifocal or toric lenses in already astigmatic cornea, then it's really worse. Now question comes, why there was a need of Pathwalia's butter knife chopper? I would like to share with you some videos. Excuse me. Videos. Okay. Now this was my traditional method where I used to give a scleral incision and used to bisect with the wire rectus and Sinskey hook. Now look at that. Sometimes while trisecting the nucleus, there is a snip. It just slips very fast. Look at that. So as far as the lower grades of cataract are concerned, I'm not worried about it. But what about the harder cataracts? Next. Okay. Now look at this. This was a case of Argentinian flag. The posterior capsule was not at all stable. I wanted to take out this nucleus, a very, very large nucleus, through 5.5. I managed to bisect. I tried to bisect the nucleus. Now see what happens. It was so hard, I was pressing as if the metal is going to break, and suddenly see what happens? It slipped. So it hit the posterior capsule, there was a vitreous loss, ultimately anterior vitrectomy was done, and the lens was implanted in the sulcus. So that's why we needed something which is very, very sharp, which has been made by a lathe machine, and it is so sharp, I'm going to just show you. Sorry. Play करना है. Okay. चलो कोई बात नहीं. Back करो, back. वो पीछे करो यार. Okay. Now here, this is the Pathwalia's butter knife chopper. This was probably the first case I have after I got my instrument. Now it is so amazing. Just go inside. You have to place this chopper right on the nucleus, press it very little, and give it a scratch. Now see, it has already been divided. You can appreciate the margins of the nucleus, which are very, very sharp, and it's very easy to do it. Now after this, next video. So then I tried 2.8 millimeter incision. Look at that. This is after 10 days. I will be showing you more cases. Now this was again grade 3, grade 4. This is the side port, how you give. And let me just make it, this is the main port, and this is the capsulorhexis, and this is how you bring the nucleus into the anterior chamber. Now again the same instrument, Pathwalia's butter knife chopper with a wire rectus. You have to use copious amount of visco above and below. And now since the size of incision is small, I'm going to trisect the nucleus with a great ease. So now this is how it goes in. With the support of the wire rectus, you have to just place this instrument over it and give it a scratch. Now go to the other side. Similarly, press it and give it a scratch. Now you can stabilize the globe using the same chopper, and you can just come out. let me just show you. Now, after cleaning the cortical matter, now here you can see there is a bit of shallowness, nothing much to worry about. You can just hydrate the wound at the end. After injecting the IOL, here. In all my cases, after implanting the IOL, I use a manual keratoscope just to visualize the anterior Purkinje image, whether the Myers are circular. This is how I hydrated the wound. And this is, now I'm happy, it's absolutely circular. This gives me a rough idea that how my patient is going to behave. Now this was the first post-op day. You can see pupil is well dilated, air in the anterior chamber, and this is after 10th day. You hardly, the wound is hardly visible. Yeah. Now these are some of my pictures of first post-op. You can see it here. Air in the anterior chamber. And this one which you see it on your right side, this is temporal 2.8 millimeter incision. This is the first day. You can see the air in the anterior chamber. And in the lower pictures, what you see, there is a bit of corneal edema in the upper part. This was a hard cataract which was taken out by trisecting the nucleus, but nothing much to worry about after 10 days after using your hypertonic solutions, and this cornea becomes absolutely clear.
7 days.
Now to sum up, I would like to say that this Patwalia's butter knife chopper is an excellent tool in the advancement of manual SICS. Not only this, that it divides with ease, it also reduces the number of steps taken for the surgery. Since the sclera is not involved, so healing is not a problem at all. So after follow-up of about 4 months, my patients are doing well. The astigmatism is not much. Thank you.
Thank you, sir, for this beautiful innovation.
Is it commercially available, sir?
Will be soon. Will be soon, yes.
One
Yes.
edge of iris repositor.
So this was sharpened by the laser lathe machine. It's a laser one.
So I
Indo-German people are having
I
this.
don't want to add one more instrument on my table.
That's
So this is my iris repositor. You
Yes.
just sharpen one edge 6 millimeter
Yeah.
for that, and I've used that. That is also
So I
very
got
much
the idea
effective.
from there only. Iris repositor,
Then
yes.
I asked sharp edge people to make disposable nucleus cutters.
Wonderful.
So
Sir, what
yes,
grade
those
of
are
cataracts
available.
you are doing with this?
Up to grade 4, they are doing very, very well. But in grade 5 and grade 6, I've got a very bad experience, I should say, because the nucleus is so big. As such, the pupil are not very well dilated. The space is very less. In huge cataracts, in a small AC, if you want to do trisecting, it's very, very difficult. You're going to damage the endothelium. Secondly, the endothelium stripping is very common in such cases. Since the zonules are also very, very weak, you will end up in more complications. What I have seen in my practice, grade 5, grade 6 is very, very less. So if you want to give, already they can't see anything. 6 by 60 is the vision, and even less than that. But if you give them 6 by 9 vision aided, they are more than happy rather than to go for a complication. So what I'm going to do is I'm going to divide the nucleus in the bag, then take it out one by one piece so that it's easy to do it.
So can we use it from the side port?
Yes.
With the
you
other
can.
end?
Yes, you can use it.
So we can use that.
But the
this
only
side
problem
port.
with the side port is because we want the division of the nucleus to be aligned longitudinally
Yes.
with that of a wound. Now, if you're going to go from the side port, it will be the opposite side. Then you will be manipulating more and more to dilate again and to align the nucleus with that of a wound. It will take more and more of steps. So that's why only the main wound, this is going to help a lot.
Sir, which visco you are using?
Normal.
So it is very good innovation, sir.
Yeah, so nice. Thank you so
Really
much.
Good innovation.
Fantastic.
Thank
I
you.
use sodium hyaluronate.
Okay.
That certainly will create the space
Yeah.
and adds more things.
Yes.
One thing more I would like to suggest you for
Yeah.
grade 5 or 6, whatever you say.
Can we take the next
We are
patient?
using cystitome
Yeah.
with the needle.
Yes.
You can have visco in that,
Oh.
enter
Acha.
and scratch.
Scratch.
Keep on scratching with that
Hmm.
same cystitome from where we are making
Yeah.
capsulotomy,
Yes.
capsular axis, and after that scratching, your Batwalia's knife or my iris repository.
So nice. Yeah, thank you
Thank
so
you.
much. Thanks a lot. Thank you.
SICS was invented as a solution for surgically induced astigmatism of ECC, but ironically has been struggling to please the masses in this era of phacoemulsification on account of induced astigmatism. I invite Dr. Jitendra Bali sir from Delhi to elaborate on the statistical perspective of this problem.
All right, so we're going through a 180-degree U-turn now. The primary perspective of this talk is to understand, we've been talking about surgically induced astigmatism a lot, which is a lower order aberration, and there are higher order aberrations also. What we don't understand is the maths behind comparing this method of evaluation with that method of evaluation. This is a very big topic, and I won't be able to cover all of it. This is just a primer to set you thinking about what it is, and of course, about setting up a journey of research in this field. At the outset, I want to thank ISMSICS, Adesh, POS, and Professor Rajwinder for giving me this opportunity to talk to you about statistical perspectives on surgically induced astigmatism in manual small incision cataract surgery in this very vibrant place and a very hospitable place. So without wasting further time, let us embark on this journey. Astigmatism, of course, is a toric surface having two different foci and an indeterminate focus in between, which we call the conoid of Sturm, of course demonstrated in 1800s by Young. And then what we started doing was we said that there are different types of it. We started classifying it as at 90 degrees, at 180 degrees, with the rule, against the rule, at 45 degrees, at 135 degrees. And this was regular astigmatism where one principal meridian was at right angles to the other one. What happens if the principal meridia are angled to each other? Then you have irregular astigmatism. And this is what you are going to get in your surgery also. Now you come to the methods of measuring astigmatism. Now evaluate it in such a manner that you have a wave front which is coming. It is coming to a perpendicular surface, a surface, the cornea, and the optical system of the eye, which is at right angles to it. So your retinoscopy and aberrometry are measuring it in the plane of the wave front. And your keratometry, your corneal topography is at right angles to it. You are making an incision in the keratometric plane. And then you are evaluating two different things. One is in what is happening to the wavefront, the other is what is happening to your keratometry. So that is one area where we need to understand what exactly was it that we were measuring. So you cannot compare apples with bananas. You have to compare apples with apples, bilkul. So of course, for keratometry we had different rules that if keratometric value is this much, on the keratometric plane, in the spectacle plane, it will be like this. But that was holding true for phakic eyes. For pseudophakic eyes, whether the Jawal's rule holds or not, we are still not very sure. And then, of course, came in another thing was neuroadaptation. Now, what we saw in late 1960s and early 1970s was something called pseudo-accommodation in the pseudophakic patient. This was described by Peters, and he said that, a little bit of myopic astigmatism gives a very comfortable vision to your patients. So even if he has, astigmatism, even if he has some aberrations, his brain adapts much better to those aberrations that we are inducing. Now, I was talking of that circle that you have at the limbus. You are cutting one edge of it. So So it was Donders who described it, and Cravey said that this is like a hula hoop. You cut one side of it, the other one goes, like one side becomes larger, the other one becomes shorter. But now, this is not just a circle, this is a dome. And it is an elastic dome. So whatever you are cutting is inducing a flattening in the steeper axis where you've cut, and it is inducing a steepening in the other axis at 90 degrees to it. So now you've got the law of elastic domes. And now the problem that arises is it is not even an elastic dome, because an elastic dome is what? It should not have any thickness. Your cornea has a thickness and your cornea has a biological membrane also. So now your mathematical considerations are now going to change. What were the methods we were using? The first one was, of course, the simple subtraction analysis, highest minus lowest. It gave us some amount of information. It was very easy to compare, but there were problems with it. What were the problems? If I have time, I'll try to discuss. Otherwise, we can discuss it over lunch. Then we came to polar analysis. We said that, let us convert the cylinder into vertical and horizontal axis at 90 and at 180 degrees. And that gave us, the with the rule and against the rule. So you convert it into, you use a cos theta and a sin theta. And once you have, broken the given vector into two, you are able to do a minus and a plus of a pre-op versus a post-op. Then came our vector analysis, and the vector analysis came with its own problem. A vector had what? It had magnitude, it had direction. So you had a preoperative magnitude, you had a preoperative direction. You had a postoperative magnitude and a postoperative direction. And the difference between the two gave you a third vector which again had magnitude and direction. This looks very good when it is for an individual patient, and explain it to an individual patient. When you want to summate it over a population, there is a problem. Because now you have the situation where 180 degrees and 90 degrees, like when you add the direction of the vectors, it makes no sense. So we came up with this concept of something called the centroid. What were the different approaches people used? This was Gartner's decomposition. He said, okay, make it vertical and horizontal. There were n number of approaches that were described by different authors. I am not going into the details of those ones. Most important one was Nasser's. And so now we've got this. We've got aberration analysis. We've got keratometric analysis. We're talking about keratometric analysis right now. And this gave us the ability to compare, different methods. But over a period of time, we started realizing that, it is not possible to describe the astigmatism using only these methods. So we started talking of, okay, I will be curtailing it. So we started talking of Fourier analysis, and we induced the concept of something called the surgical vector, which was the opposite of it. So what we started doing was, we said, let us have a summary measure where we say that, less than half a diopter in that many percent, less than 1 diopter in that many percent. That allowed us to compare different techniques with each other. But was it giving us the full picture? The answer is no. So what you need to do is, you need to have different summary measures and give different approaches. And we started talking of these. Look at it, Houtling's T2 statistic, which is bivariate probabilistic analysis. Then we started looking at different multivariate analysis, which is beyond the scope of the present discussion. And then we had multiple methods which have been described. One of them being this one. And this gave us a theoretical construct. Again, we are going back to the drawing board, and we are looking at discrete mathematics and eigenvectors now. And in ISMSICS, what we are trying to do is, we're trying to look at one method wherein we, combine 4 or 5 different methods and give a composite picture. And we are very close to coming out with something which is not the exact solution to the problem, but it will incorporate a lot of methods from cornea, and it will be modified for cataract surgery, because astigmatism is a lower order aberration which has an effect on our outcomes. And at the same time, we also want to look at the higher order aberrations after cataract surgery. With that, I close my talk and I open the table to our learned panelists.
Yeah, very nice. And Bali is one of our mathematical talent, he's so good. But people don't take him seriously because he is a lollipolly, happy-go-lucky person. So, but he is in charge of our research platform, and we want a lot of things happening on that platform. We are working on that platform. Thank you, Jatinder. You are wonderful. Thank you.
Thank you so much,
Is
sir.
extraordinary.
Lots of maths. Thank you, sir, for this well-researched talk. As we enter the era of advanced refractive surgeries, we aspire to achieve spectacle-free, perfect vision after cataract surgeries. We are fortunate to have with us today Dr. Jagannath Boramani, sir, to give us an insight into achieving this feat without expensive toric IOLs for up to 2 diopters, using techniques of surgically correcting astigmatism.
Yeah, good morning all of you. First of all, let me thank Dr. Rajvinder Kaur, her Department of Ophthalmology, the entire team and the Adesh Institute for giving us this opportunity. Respected dignitaries on the dais and in the auditorium, let me now explain you how we can try to customize the incision or try to control the astigmatism only with SICS without doing a surgery with the machine. Let me start with 2 cases. This case has minimal astigmatism, only 0.13. I did an SICS surgery and there was practically no change in the astigmatism, or I have not induced any significant astigmatism. Let us consider another situation. This is a case of significant astigmatism of 2 diopters. This patient was operated for the other eye with phaco and without toric, so her astigmatism remained the same. She has 2 diopters of astigmatism in the other eye, but here I operated with SICS and I could significantly bring down her astigmatism. So how is this possible? If you want to neutralize, you can neutralize a big astigmatism, and if you don't want to induce anything, you can't induce anything. So this is possible with customized incision. The scleral incisions are very secure incisions, they are safe incisions, they heal very well. The principle is very simple. Most of you are aware that a straight incision of about 1.25 to 1.5 diopters induces about, straight incision of 6 millimeter induces about 1.5 to 1.5 diopters of astigmatism. This is in case of superior incision. This is a very purpose. We take a curved incision, which is called as a Fron incision, to bring down the astigmatism to 0.75. Now, as a corollary of this, if you try to make the incision more and more curved, what will happen? Naturally, the induced astigmatism will be less and less. The ends of the incisions are going away from the limbus, so naturally the astigmatism induces less. So this technique I am using, this principle I am utilizing in my technology. So after doing lot of cases with different types of incisions, I have formulated my own algorithms. For example, a superior incision of about 7 millimeter will induce 1.75 diopters of astigmatism. Try to reduce the size of the incision and the induced astigmatism will be less. Now, if the incision is a curve, again it is further reduced, and if you have got almost a U-shaped incision, there is no induced astigmatism. So you have to titrate the incision according to the pre-existing astigmatism. All the incisions in the between 60 and 120 meridian are considered as superior. The temporal incisions are comparatively weaker in inducing or neutralizing. Even a straight 7 mm will neutralize only 1.08. If it is a small temporal incision, it will not induce much, and if it is a temporal curve, it is practically ineffective. The superior nasal and superior temporal incisions, their behavior is in between superior and temporal incisions. So whatever may be your size, shape and curvature of the incision, try to keep the incision, the center of the incision exactly on the steep meridian. As you saw in the live surgery, you mark the steep meridian and center your incision on that steep meridian. Now where to sit for the surgery? In both the eyes, you get almost this half area to operate, whatever may be the axis of incision, and nose will not be a big problem. So for finding out or calculating your results, put one type of incisions in one type of table and calculate what is your mean induced astigmatism, and then you can form your own algorithms. Now let me show you few example. This case has only 0.28 diopters of astigmatism, and I have further reduced to 0.18 with a U-shaped superior incision because the steep axis was 100. This is similar case, superior temporal steep 0.39 brought down to 0.22. Now this is case of 1.12 incision. So I took a straight incision superior 6 millimeter centered on 97 meridian, and it came down to 0.15 only. So on and so forth. Now this is a case of very high astigmatism, 3.49 diopters. Patient was not affording a toric IOL. So I did an SICS and substantially reduced the astigmatism. This is her 7.5 mm straight incision centered on the steep meridian. Second case, this was affording patient. He could have gone for a toric lenses. I told him both the options, go for a toric lens or opt for my method. And with my method only, the induced astigmatism was very high, and I brought it down to 0.56. So here I charge more as surgical charges. So instead of paying to a lens company, patient paid more to me. So I promote this as a premium surgery with or without premium IOLs. In the first case, the charges were not more because patient was not affording. So I consider it as a charity given to the patient. This is a doctor patient, 1.97 diopters. Steep axis was 170. On AutoCAD was showing 165. This is the left eye. So I practically knocked down the astigmatism with a superior nasal straight incision. So this is his post-op. He is not accepting anything. So this way you can play with your incisions and astigmatism. This is a very recent case. If you see the dates, it is this month only. 0.27 brought down to 0.17 only. So I stopped calling it as a surgically induced astigmatism. For my methodology, we should call it as a surgically corrected astigmatism. The upper terminology is something like unwanted pregnancy, and the lower one is like a planned child. So I call my surgery is not a small incision cataract surgery, but let us call it as a KICS, the customized incision cataract surgery. So to have a perfect result, you mark the horizontal and vertical meridian as you saw in the live surgery. So you know about the cyclorotation when the patient lies on the table. So to minimize the errors, I mark the horizontal and vertical, and then when the patient is lying on the table, whatever is the steep axis, you mark it again using a degree gauge and reference marker, and whatever is your type of the incision, you center the incision exactly on that mark. Here the marking is done only on the incision size. So right side you can see there is a straight incision being planned with the mark and the center, and the left side it is a curved incision. So this has been published by us in Indian Journal of Ophthalmology. Dr. Bali has helped me a lot in this publication. So let us consider two similar cases. In even see scleral incision, the results are not perfectly predictable. Same is the case with cornea also. Even with a toric lens and with phacoemulsion, sometimes there can be erratic results. Sometimes I also get some erratic results, but at least 80% of the times we are coming very close to the target. Imagine there are two similar cases having exactly 2 diopters of astigmatism. Exactly on at the same meridian, and the same methodology is applied. But imagine that there is undercorrection in the first case. Instead of 2, only 1.5 undercorrected, and the remaining astigmatism residual was 0.5. In the second case, imagine that there is an overcorrection, 2.5 diopters got neutralized, but still the residual astigmatism is 0.5 only, because you are erring on either one side of 0 or the other side of 0. So if the range of error is say 1 diopter, the end result is only half of that. This is the advantage of this technique. So with customized tunnel engineering, it is possible to wipe out or at least minimize the stigma of astigmatism. Thank you very much.
Very nice anomalies. Thank you, sir, for this important practical know-how. We are a Jugaadu nation of innovation, where ISRO achieved the remarkable feat of sending Mangalyaan to Mars at a budget less than that of a Hollywood movie on the same subject. We embraced femto-assisted laser surgery, but persevered to deliver similar results at an affordable cost. This dream has been realized, and today Dr. Sahu is working relentlessly to share his pioneering technique of 2 mm small incision cataract surgery with phacofracture to deliver low astigmatism with good visual recovery. I invite Dr. Amulya Sahu, sir, on stage.
I've been asked to break the monotony and talk something on the life and how to, profession, how to excel in both. And I will not take much time. See, how many of you think you are permanent here? Raise your hands. So nobody is permanent. So we are visiting this planet for a short time. And if I say we are cosmic robot, how many of you are going to agree with it and disagree with it? You have no answer. See, we are making robots. The control is in our hand. Suppose we leave that control, what happens? It will destroy itself or it destroy others. And we wanted to visit this planet, the higher intelligence. If we have intelligence to create a robot, the higher intelligence also has a capacity to create us. This is the perfect instrument he gave us. Now, if I say, suppose I say Karamjit, how many Karamjits are there in you? He will say, this is me. But Karamjit not one, Karamjit is 4. So once you know yourself, then you can know everybody else. What is happening, we are ignorant about our own dimensions, and so we create confusion in us and confusion everywhere else. So Karamjit is 4 means this is the biological car which the creator gave us. Go and see this planet. So this is running by electric currents. If I cut one nerve, it will not function. So this is not me, this is given to me. My nose is my brand, and he fitted 5 sensors. The nose, ear, tongue, touch. Then to know this world, we need these sensors. Now, he fitted a computer, which is a biological computer, and whatever programming you do, you become. You say, I want to be the best thief in the world, you become the best thief. You say, I want to be the excellent human being, you become excellent human being. It all depends on your programming of the computer. So it is called Kalpataru, the wish-fulfilling tree. Whatever you want, you can become. Because whenever we are taking one step, we are doubting our step. That is getting recorded. So we don't progress. Now you focus on that, you can really excel anywhere else. Now he gave us a feeling. This is a thinking me, this is a feeling me. The feeling me is an air conditioner. If you have a loving heart, your driving is cool. If you put it in sort of hatred and other sort of nonsense, then your driving is hot. So it is a machine, this is a machine, this is a machine, the eyes are camera which is taking photographs and processing it. So where is Karamjit? When the morning when you get up, you say, I saw a good dream. Who saw the dream when you were sleeping? That is the real you, that is the visitor, that is the witness, that is the driver of this car. It never sleeps. In Gita, that reference is there, Yani sa sarvabhutani tatra jagrati swayami. जब सब सोए हुए रहते हैं, जो स्वयं को जान लिया, वो जगा हुआ रहता है. And all our saints and always told that, but we have no time to understand or connect with that thing. If we are all the time looking at our robot, our creator is next to us, he is always looking at us. We have forgotten him, he never forgets us. The problem comes when you feel that, oh, I am the big gun, and that is when you are becoming a balloon and it is waiting for puncture. So when you say that I am here, you help me to serve you better, so that the surrendering attitude makes you something somewhere. I will tell about a character who started from a village long back, and the village didn't have electricity. And that person was just trying to find himself, and he went to a profession where he felt that, no, I don't belong here. And then he came back and he started becoming a doctor, and he started from there, and again he got into become a paramilitary doctor, and then he said that, oh, this is one life, I cannot waste it here just writing ABCD. Then he went into back to the medical and did his post-graduation, and then so this thing went on. Then he was aspiring to be something, express something. So that is where he found himself. That character created something for himself. He said, this is one life, I should leave something behind. Now he wants to make a village hospital, and then this is the profession comes in. When I know myself, I am happy because I understand myself, though immediately there is no room for conflict. If suppose your wife shouts at you, it is up to you to see where that thing is coming. If you see that somewhere disturbance is there, why you accept that disturbance? You can just listen and that will pass off. After some time, there is some things will be repaired. But no, why that ego comes in? What is ego? It's a conditional identity. And why we should be based on conditional identity? Why we should not search for our absolute identity? Aham Brahmasmi, that thing, why it will not come? Because we don't want to. Somewhere we feel we are small, and we end up being very small. somewhere you think you are the great. Then you become great, not that because you are associated something different, but you are a part of the higher intelligence, and you expressing him in your work and behavior and everything. So if you see that what Charlie Chaplin has said, nothing is forever in this world, not even your problems. Most today lost of life is the day we don't laugh. 6 best doctors are sun, rest, exercise, diet, self, respect, friends. Stick with them and enjoy happy life. So, as I said, to excel in life, you have to understand yourself. And in our scriptures and everywhere, you will see that we are principles. If you Shiva and Shakti, we say that there is a God sitting there and with a wife. It is not like that. This topic can go on for hours, but I will try to say that it is not like that. It is a principle. Shiva principle and Shakti principle. We are representing that principle in ourselves. And suppose you don't want to be Shiva. Shiva means what? Static energy. Shakti means what? Kinetic energy. There is a play of energy happening everywhere. And suppose Shiva is static. He said that, why? You go on dancing, whatever you want doing, I am here. And then Shakti blesses him. But we are getting shaky, the Shakti is going to kick you always. So that is wife and husband's relationship. If you are not stable, you are not saying, I am there, now do whatever you want to do, the Shakti comes back to bless you. So you have to be a Shiva then. And that is the process of sadhana, whatever we are doing in our profession. We are every day I am doing for the last 27 years, I have not met a single day of yoga. Yoga means what? To join with yourself. And what which self? The 4th dimension, which is called Turiya. That is where you have to go. When you go there, you are blessed. When you go away from there, your centrifugal forces catches you up. Then you become a mad person. You are imbalanced. The more you go away from the center, the centrifugal process goes on increasing. Then you are become decentered. That is what the madness or whatever name you give. And what these people are doing, giving them medicine to silence the mental wave. With yoga, I started with, when I started my life, I was president of my college. Everybody was thinking, I am a great person, but inside myself, I was really going hell. Because my mind was like waves after waves were coming. I didn't know what the hell is happening in me. But now there is no wave. The yoga helps. In the end, what I will say, do everyday yoga, give 1 hour me time, go and run for at least 1 hour, 30-40 minutes, you go fast walking, then exercise and yoga, because you have to invest. If you are not investing on your body, in your thoughts, in your emotions, then your check is going to bounce. If you have got a wife, you have to invest somewhere. Otherwise, you are asking, give me this, but you have not invested anything. How you will get? The check will bounce naturally. So this is what I say. Profession is the same thing. Profession means what? To make a statement, profess. So what statement we want to make with our life, it is our choice. So that is why I am telling you, don't make it limited that I want to earn something and leave. That sort of, leaving thing is not our goal. Even the birds are leaving, so what is the great deal here? Having a car, having a house, having these things is not the identity of you. What you are going to leave behind is going to be your identity. Thank you so much on this. Yep. So my next topic, now coming back to our scientific approach. See, when I started this thing, they are doing SICS because everybody else was saying, I have this machine, that machine, that machine. So that is the time I was the president of Bombay Ophthalmic Association. I thought this is not fair, because these people are, they are preventing blindness, they are solving so much of problem, and they don't have a chance to talk about that thing. So I said I must give them a platform. Nobody believed in it. So, but then I thought we have an inferiority complex, so I never propagated SICS in India. I went abroad. I went to Southeast Asia and did so many conferences there. My friend Jagannath has gone to many conferences. My first conference was Malaysia. People started praising, they are celebrating us, and then India wake up, and he became the, continuously he published so many journals, now he's the executive chairman. So that time I was just challenged, ki if FECO is doing a small incision, can we do a smaller incision in SICS, then to be taken seriously. So I went on reducing the size of the incision, modifying my instruments. Ultimately, on 2005, I demonstrated 3 millimeter SICS in Natarajan's place. And then a 2 millimeter I did in All India Institute in Udaipur. And after that, it is history. So I am now focused on training the trainer, so that it percolates to the next generation. So this is my only goal now. And we have grown so much now. All the world wants to know SICS. So if they want to know, we must have research, we must have to go do many things innovative. So all the brilliant surgeons are there. I want to catch them as soon as possible. So now this thing in a small incision, I have 2 millimeter, lot of work has been done. It has been published in the IJO also. So we are not creating any astigmatism, that much I can say. The conjunctiva used to be cut so much, now there is no need to cut that much. In this incision, the principle is the 1 millimeter behind the limbus, 2 millimeter incision, parallel back cut of 1.5 millimeter. With that, you can inject the lens or you can directly put a foldable lens. But if you are giving a 2 millimeter back cut, then you can put a PMMA lens also. Now there's some modification I did for my own convenience. If it helps others, is okay. This is a single jet cannula. Many a time in the SICS surgery, the cortex and other thing get deposited before the on the endothelium. So if you don't flush it out, you don't see proper view inside. So this jet cannula just mildly, otherwise if you have a big force inject something, the endothelium may get edema. So this is a single jet cannula, and second one is a multiple jet cannula. So any time in the tunnel, the cortex remains there, it creates irritations and other things. Patient comes back to you, always complaining of foreign body sensations. And that multiple cannula, you flush it out so that it becomes very thin. And this is what, see, we have a visco cannula. This is a visco cannula. I compress the tip, so make it flatter, so that it can go with a flat incision in the side port. Now this is my marker where I mark the axis, and this the modified cannula is a gauge I have reduced, and I have made some modification there which helps me. And this is my modified vectis which helps. Now I'm cutting this thing, but that is not my innovation, that is Jacobi's thing I am using. Now I will show it has been demonstrated yesterday, but I'll say I'm dividing the nucleus and in the AC, in the bag, and in the tunnel. So 2 millimeter is not an answer to all kind of SICS surgery. It is a choice. And if you are moving, you have done thousands of operations or at least mastered the technique properly, then only you do this. This is, if you have a grade 1, grade 2, grade 3, there is no problem. Grade 4, then you have to divide the lens into few pieces if you want to take out with a 2 millimeter. Because there is no problem, because we are creating a big pocket there. The space is available, so the resistance is not that much. But fear is that it is a small incision, but it looks small outside, but inside we have the lot of space. So the pocket is the main important thing. The steps of surgery is normal, normal step, nothing more. Only I give 2 back cuts. This total thing, I think, will be 3 minutes. So those who have seen yesterday's surgery, you have seen I have took a wrong decision. If you have a very hard cataract and you divide into 2 pieces, then resistance will be there. I should have divided into 4 pieces and brought it out. But that because of the resistance, there was little iris prolapse. So that can happen. So you have to be watchful about that, what kind of lens is there, and then you plan your surgery accordingly. See, this is a soft cataract, so there was no problem in bringing it out. Now this is a tunnel breaking that was there. Now it is. I will just show the dividing in the bag. Yeah, 2 pieces. You can make it 4 pieces there. Now I will come to the next. Is the AC division. AC division, what happens? You have to, the vectis is kept on the iris diaphragm, and your hand should be really stable. So you hold the vectis there, and with the visco cannula, which is flattened in the tip, you go on injecting visco, creating a space between the lens and the endothelium, and then go on pressing the nucleus over the vectis, and then it divides into 2 pieces. But I think I have to add a cutting edge to that cannula, so it will slice the nucleus there. Well, I should have only shown the division part, but it is there, so I don't want to, those who are beginners, let them have a look. As you can see that this is also a soft cataract. So I will like that if anybody is interested, they can ask the question. After this, I am going to stop it because there is no point going into details of statistics and other things. Time is limited. So I will show the division part, and then if there is any question, I would like to insert it. See that I'm put, the vectis is stable on the iris diaphragm, and now it has been divided. And now you just drag it out. Okay, any question? Or I'll stop. Thank you.
Thank you, sir, for a beautiful talk on this new innovative technique, as well as giving us the secrets to living a fulfilling life. I now conclude the first session of this conference and thank all the chairperson and panelists and request them to kindly take their seats. I now invite on stage our dynamic Professor and Head of Department, Dr. Rajvinder Kaur ma'am, a beauty with brains. She's a true multitasker and the beating heart behind this academic extravaganza. Enthusiastic and driven, she leads by example. Dr. Rajvinder ma'am.
A very good morning and a warm welcome to the third conference, Cataract Conference, Complete Cataract Conference of Punjab chapter of International Society of Manual Small Incision Cataract Surgery. We at Adesh are honored and delighted to host you all for an academic and professionally enhancing experience. My heart swells with pride to welcome you all at Adesh, a renowned medical education and research institute with the state-of-art of multi-speciality hospitals. In a span of less than 3 decades, this dream, envisioned by Dr. Harinder Singh Gill, has become a synonym of excellence in healthcare. So the institution has risen to the new heights, achieving unprecedented success under the passionate and visionary leadership of Dr. Gurpreet Singh Gill. He is the wind beneath our wings, a guiding light and sporting hand, urging us to create a biome of knowledge where fertile minds can grow and learn. I welcome our Vice Chancellor, Sir, Colonel Jagdev Singh, Sir. He is our guiding star, a disciplinarian with kind eyes and humble manners. I request my PGs to Harleen, go and felicitate VC, sir. I welcome, sir. Sorry for the delay. I welcome Dr. Harkiran Ma'am, Dean Faculty, a legendary professional and academician, and he is the cradle of warmth and encouragement. I welcome our principal, sir, Dr. Pramod Goel, sir, renowned for his pleasant smile and assuring personality. He is the most approachable and always eager to help. I welcome Dean Academics, Dr. Varun Malhotra, sir, an intellectual rich in experience, kindness, and always willing to support us. I also welcome Dr. Harijot Singh Bhattal, our Deputy MS and my better half. He is diligent, sincere, and tireless. For me, he is the key to all doors. I am honored to welcome Dr. G.S. Dhami, President Boss, a true luminary whose blessings hand always fills my heart with newfound confidence. He is an inspiration, constant source of encouragement for all the academic activities. And our own Boss family has been akin to family since I ventured. Dr. P.S. Bharat, sir, I welcome from the bottom of my heart P.S. Bharat, sir, the master hand, my go-to person. He is the reigning president and the pillar of the boss. Thank you so much, sir. Our very own Bathinda Ophthalmological Society has been akin to family since I ventured in this region of Punjab. Forever supporting and nurturing, they have been trustworthy companions of my journey. I am privileged to extend my warm welcome to our distinguished national faculty, Dr. Amulya Sahu sir, a legendary being within a vibrant smile, undying energy, a master painter, motivational speaker, and pioneer of 2mm SICS. He is the harbinger of SICS, sharing the gift of this beautiful surgery born in India with the world. He is the boost behind the hordes of young ophthalmologists yearning to learn this art. I rekindled my love for SICS and introduced me into the platform of International Society of Manual Small Incision Cataract Surgeries. I am humbled to welcome Dr. Jagannath Boramani, an executive chairman of International Society of Manual Small Incision Cataract Surgeries. He is a supporting pillar and powerhouse behind its smooth running. He is the all-rounder, a gifted singer. He is the inner of the axe chopper in the cataract surgery. I now welcome Dr. R.S. Taliwal sir. He is the common thread which links all the ophthalmologists in this region of Punjab. I welcome Dr. Pradeep Hanta sir, a teacher at heart. He has been guru to all of us by sharing his meticulous and elaborate surgical videos. Trained at best institutes of nations, and he is the diamond whose light enriches us all. I welcome Dr. Jatinder Bali sir, an avid researcher and past library officer, that is the Delhi Ophthalmological Society. He introduced me to Sahu sir and Boramani. I now welcome my contemporaries and passionate teachers who are at the heart of educational institutes nurturing the next generations of ophthalmologists. The head of department of all medical colleges, Dr. Karamjit sir from the GMC Amritsar. He is the president of Punjab chapter of International Society of Manual Small Incision Cataract Surgery. He is focused, juggling multiple projects at once with the finesse. I also welcome Dr. Shakeen Singh from SGRT Amritsar. I also welcome Dr. Manish Dhawan, Dr. Anuradha Raj, who personifies the saying that the real queens fixes each other's crown. She is a rock and support system. Dr. Gurvinder Kaur, the HOD of DMC Ludhiana and dear friend. The Punita Garg, HOD of Adesh University and Ambala. And Dr. Vartika from the Gyan Sagar Medical Colleges. I also welcome the current and the past office bearers of Punjab Ophthalmological Society, Bathinda Ophthalmological Society, International Society of Manual Small Incision Cataract Surgery, and the Punjab chapter. I also extend a warm welcome to all the delegates whose presence is key to the success of our conference. I encourage all of you to take the advantage of this opportunity to engage and share insights and foster new connections to continue learning. I call upon on the stage Dr. Karamjit Singh, the President of Punjab chapter of International Society of Manual Small Incision Cataract Surgery, to say a few words and introduce Dr. Sahu and Dr. Boramani on stage, and surprise later on.
Good morning, respected Dr. Harinder Singh Gill ji, Chairman Adesh Group, Colonel Jagdev Singh ji, Vice Chancellor Adesh University, Dr. Pramod Kumar Goyal ji, Principal Adesh Medical College, Dr. Harkiran Kaur Khera, Dean Faculty, Adesh Medical College and University, Dr. Harjot, Deputy Medical Superintendent, Dr. Amulya Sahu, Founder Chairman, International Society of Manual Small Incision Cataract Surgery, Dr. Jagannath Boramani, Executive Chairman, ISMSICS, Dr. Pradeep Mahanta ji, Member Scientific Committee, All India Ophthalmological Society, Dr. Jatinder Bali ji, Chairman International Research Committee, ISMSICS, Dr. Ranjit Singh Taliwal, Chairman, ISMS SICS Punjab Chapter, Dr. G.S. Thami, President Punjab Ophthalmological Society, Dr. P.S. Broad, President Bathinda Ophthalmological Society, and senior faculty members and distinguished guests. So this is a third conference of International Society of Small Incision Cataract Surgery Punjab Chapter. So I am just briefing about the society and Punjab chapter. So we all know that it is basically brainchild of Dr. Amulya Sahu ji, who formed this committee way back in 2005. So when he feel that this technique of cataract surgery, the low cost and affordable cataract surgery technique should be made available to the communities. It should be practiced not only in India but all around the world. So he basically organized his team to develop such programs that manual small incision cataract surgery should be made popular at world platform. And we are seeing this, that ISMSICS is now has chapters in more than 24 countries all around the world. So we started Punjab chapter of ISMSICS in 2020 with encouragement from Dr. Amulya Sahu and Dr. Ranjit Singh Taliwal, who is founder chairman of Punjab chapter of ISMSICS. With the efforts of and with the support of Kumar Vikram Taliwal, Dr. Kumar Vikram Taliwal, who was pioneer at that time in this technique in Punjab. So he motivated us to organize first conference of ISMSICS in Amritsar, and that conference was a huge success, and on that occasion only we formed Punjab chapter of ISMSICS. After that, we conducted our second conference after the COVID in Amritsar only, where Dr. Sahu has successfully demonstrated 2 MMSICS and also taught us 2 MMSICS in our operation theatre at Government Medical College, Amritsar. He performed 13 surgeries, 13 2 MMSICS over there with a great success of that conference. Now we are thankful to Dr. Rajvinder and the team of Adesh Institute of Medical Sciences, who has successfully organizing this third event of ISMSICS. So we have witnessed an excellent live surgical session yesterday with talks from the experts in this field. So without taking much time, I am thankful to Adesh Institute of Medical Sciences and Dr. Rajvinder and her team and Bathinda Ophthalmological Society to give us opportunity to organize this conference in this medical college. Thank you very much. Thank you all.
Now I invite VC sir, Dean Faculty, Dean Academics, Principal sir, Deputy MS sir, Dr. Sahu sir, Dr. Boramani sir, Dr. P.S. Barat sir, Dr. Dhami sir, so to please grace the stage. So we will do the lamp lighting first. I also invite the office bearer of Punjab chapter of manual small incision cataract surgery. Please come on the stage also.
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्
एक मिनट सर. I request Dr. Shikeen Singh, Dr. Ashwini Kalia sir, Dr. Anuradha Raj, Dr. Jitinder Bali, Dr. Rajan Gupta to please come on stage. Dr. Patwalia sir, Dr. Pradeep Mahanta sir,
I request Dr. Ghanshyam Garg sir also please, sir kindly grace the stage. Dr. Ravi Trehan sir, sir please come on the stage for the photograph. Dr. Ghanshyam sir. I also request Dr. Ramesh sir to please grace the stage. Ramesh sir. Dr. Gurvinder ma'am, kindly come on the stage ma'am.
ਪੰਜਾਬ ਚੈਪਟਰ ਦਾ ਤਾਂ ਰਿਹਾ ਨਹੀਂ ਕੁਝ ਹੁਣ
ਹਾਂ ਨਹੀਂ
ਬੋਲ ਹੀ ਦਿੱਤਾ
ਬਸ
ਮੈਂ
ਗੋਲਡ ਮੈਡਲ
ਉਹ ਹੁਣੇ ਦੇਣਾ ਪਹਿਲਾਂ ਦੇਣਾ
उनको पंजाब का काम खत्म कर दिया फिर
हाँ,
खाली
हाँ,
सीटेड कर
जी जी
Now I request VC sir to please again come on the stage. Dr. Sahu sir, Dr. Boramani sir, Principal sir, Dr. Harijot Singh sir, and Dr. SP Singh sir, Dr. PS Barat sir, Dr. Dhami sir. So we have to do a special announcement for the gold medal. So it will be introduced by the, introduction will be done by the Dr. Karamjeet and then followed by.
ਸਰ ਦੇ ਕੋਲ ਹੀ ਹੈ So on behalf of Punjab chapter of ISMSICS, so it is my proud privilege to announce that as per tradition of Punjab chapter, every year we are going to give a gold medal in the name of Dr. Kumar Bikram Taliwal, who is basically mastermind of forming the Punjab chapter of, who started rather Punjab chapter of ISMSICS, and with his support and help we were able to organize first conference of ISMSICS. So this year the gold medal is to be given to Dr. Pradeep Mahanta. I request Dr. Bikram Taliwal for this medal, Dr. Taliwal and Mrs. Taliwal to come on the stage. I request Dr. Pradeep Mahanta sir to kindly come on the stage to receive this gold medal, this prestigious gold medal of ISMSICS Punjab chapter. Thank you, sir. Thank you very much. Thank you. Now I hand over to Dr. Rajvinder for further proceedings of this conference. Thank you.
I request the office bearers of Adesh University, Dr. Bhattal sir, Dr. Colonel Jagdev Singh sir, to kindly stay back on stage for the felicitation. Dr. Pramod sir, Dr. Varun Malhotra sir, please join us. He's a Dean of Academics. I request our distinguished office bearers of Adesh University, Dr. Varun Malhotra sir, he's Dean Academics, Colonel Jagdev Singh sir, he's Vice Chancellor, Adesh University, Dr. Harkiran Khera ma'am, she's Dean Faculty, Principal sir, Dr. Pramod Goyal, and our Deputy MS, Dr. Bhattal sir. to kindly felicitate our national faculty.
May I request Dr. Sahu sir to kindly come on the stage. Sir has come all the way from Bombay to actually teach us 2mm SICS, his innovation. He's a pioneer. Now I request Dr. Jagannath Buramani sir. Sir, kindly come on the stage for the felicitation program. Now I request all the, one by one the faculty who have come down from so far off. I request Dr. Jitendra Bali sir to kindly come on the stage for the felicitation ceremony. So it was a very enthusiastic panel discusser yesterday, and today SIA talk was interesting, sir. I request Ranjit Singh Dhaliwal sir to kindly come on the stage, sir, please. He's come all the way from Nabha. So we are delighted to have you. Next, I request Dr. P.S. Barad sir. Respected sir, kindly come on the stage. Sir is one of the most renowned ophthalmologists in the region. We look up to you, sir, for your surgeries. I also request Dr. Dhami sir. Sir, kindly come on the stage. Sir has come all the way from Ludhiana. Dhami sir, we are delighted to have you here. I now request Dr. S.P. Singh sir, Controller of Examination. Sir, kindly come on the stage. यहाँ पे नाम लिखते हैं। Now I request Dr. Ashwini Kalia, sir. Sir, kindly come on the stage for the felicitation part. Next, I request Dr. N.R. Gupta, sir. Sir, kindly come on the stage. N.R. Gupta, sir. Okay, may I request Dr. Shakeen Singh, sir, to kindly come on the stage, sir. Sir is a very versatile surgeon. It's wonderful watching your live surgery yesterday, sir. Next, I request Dr. Amarjeet Singh Patwalia, sir. Next, I request Dr. G.S. Brad, sir. Sir, kindly grace the stage. We expect a huge round of applause for all the panelists, the speakers who are receiving the, yeah. Now I request Dr. Tushya. He is on the way. Dr. Raj. Do we have Dr. Tushya Om Prakash over here? No. Okay. Do we have Dr. Rajan Gupta, sir? Sir, kindly come on the stage. तालियां चलती रहे हमारी. Next is Dr. Amarjot Kaur, ma'am. Kindly come on the stage. Next is Dr. J.S. Sara, sir. Do we have you here? Next, Dr. H.S. Sodhi, sir. Sodhi, sir, kindly come on the stage, sir. Next is Dr. Sandeep Gupta, sir. Sir, kindly come on the stage. Sir is, both are from Bathinda Ophthalmological Society. Now I request Dr. G.S. Khurana, sir. Okay. May I request Dr. N.R. Gupta, sir? Sir, kindly come on the stage. Says from Faridkot. Next, I request Dr. J.K. Gupta, sir, to kindly come on the stage. We are all proud to be part of Bathinda Ophthalmological Society. Next, I request Dr. M.S. Barad, sir. Sir, kindly come on the stage. Next, I request Dr. Ghansham, sir. Sir, please stage पे आइएगा. हमारी तालियां चलती रहे, ड्राई अप हो गई हैं बीच में. May I now request Dr. Vartika Anand from Gyansagar. Ma'am, kindly come on the stage. Do we have Dr. M.L. Bagla, sir? M.L. Bagla, sir? Okay, may I request Dr. Vandana Sharma? Dr. Vandana? I think she is busy with the wet lab. Dr. Vandana? Oh. She's busy in the wet lab. We'll just give her a couple of minutes, maybe. Dr. Vandana, kindly come on the stage, please. Next will be, she has been the training faculty for SICS today. Indeed, a great help. Next, I request Dr. Neeti Garg. Dr. Neeti Garg, ma'am, again has been very helpful to us. She has been the training faculty. Ma'am, kindly come on the stage. Dr. Mansi Jindal. Ma'am, Dr. Mansi Jindal. She is again the training faculty for our wet lab session. Dr. Mansi Jindal. Doesn't look good. May I now request Dr. Amandeep Singh, sir? Dr. Amandeep Singh, sir, is the training faculty for today. Dr. Amandeep Singh, sir. Sir is busy in the wet lab session. Amandeep Singh, sir. Hanji. Next is Dr. Harpreet Kaur, ma'am. Ma'am, Dr. Harpreet Kaur. Dr. Parul Gupta, ma'am. Ma'am, kindly come on the stage. Dr. Dimpy, ma'am. Dr. Dimpy, ma'am, kindly come on the stage. Dr. Dimpy has also been the training faculty. उनको क्या करवाना है? Dr. Ravi Trehan, sir. Sir, we were to felicitate you yesterday, but sir, session got delayed, yeah. We have Dr. Tushya Om Prakash. Sir, kindly come on the stage.
I now request the Department of Ophthalmology, Dr. Rajvinder ma'am, Dr. Priyanka Gupta ma'am, Dr. Ritesh sir, to kindly come on stage and present a token of gratitude to our esteemed office bearers. Colonel Jagdev sir, he is a Vice Chancellor. Thank you for sparing your valuable time on a Sunday morning and gracing this occasion, sir. This means a lot to us. Our Dean Faculty, Dr. Harkiran Khera ma'am. Ma'am, your warmth and support means a lot to us. Ever smiling and supportive, our Principal Sir, Dr. Pramod Goyal. He's most approachable and always keen to help. Very humble. Our Dean Academics, Dr. Varun Malhotra, sir. Thank you, sir, for all your blessings and support. And last but not the least, our Deputy MS, sir, Dr. Harijot, sir. Now, I will request the gathering for a group photograph. Ma'am, photo stage pe? Please, you've spared your Sunday mornings for us. We would like a token of memory from all of you. Let's all gather together for a wonderful group photograph. Please, all of you, come on stage. Our beautiful PGs, come on stage.
Delegates and postgraduate students all are requested to come on the dais for the photograph. Dr. Amandeep, please come, photograph. Group photo for all. Everybody is requested to come here. All the delegates, faculty, PG students. Everybody who's outside the hall is requested to come. Pharma people, please, can you please tell the doctors who are standing outside to come on the stage so that they don't miss on this important photograph. Dr. Kash, are you here? Dr. Kash? अरे यार मेरी ले ली खड़ जा.
Now I request the gathering to kindly join us, proceed for the high tea. It's just close to the wet labs, on the back side of the wet labs, just around the corner. And on the first floor as well. We expect everyone back in the auditorium at 12:30 to begin with the next session. We are running half an hour late.
auditorium. Dr. Mehak. So, the next session, session 2, that is phacoemulsification, which would be dear to all of us. And we welcome chairpersons, Dr. P.S. Barad, Dr. Dhami on the stage, and panelists, Dr. Gurvinder Kaur, Dr. H.S. Sodhi, Dr. Sandeep Gupta, Dr. Parul Gupta, Dr. Ashwini Kalia. So, and we'll be starting with the next talk in a minute or so. I request all the delegates to be please seated. I request my PGs to please kindly guide the delegates to the auditorium. Dr. Panku, Dr. Navdeep, Dr. Panku, please request all the delegates to be seated. So we are starting with the first talk. I request Dr. Gurvinder Kaur. She'll be speaking on phaco for beginners. That would be very important for all the PGs. So all PGs, please take the front seat. So.
Good afternoon, everyone. I hope everybody is fresh with the brunch. So I'll be talking on phacoemulsification for beginners. So when I was given this talk, I was really feeling how a beginner feels when he has to start doing phacoemulsification. So being in a medical college, I have been teaching students. So I always tell them the same words which my teachers used to tell me when I was trained for phacoemulsification way back 16, 17 years. So like any other surgery, phacoemulsification has its own curve, steeper for few and flatter for the others. But the few wise words which we can take home as residents. This presentation is actually directed towards only residents, not to the masters. So believe in yourself. If somebody tells you phacoemulsification is difficult, you'll not be able to do it, do not listen to him or her. The most important thing which nowadays, which I feel the residents miss is they don't like observing, they like doing. So observation itself is a good teacher. You need to observe your seniors, you need to see how they do simple cases, how do they do complicated cases. You can record your own videos and observe your own steps. Where was the difficulty, what problems happened, how to rectify. So observation is very important. Choose the right case. So a very soft cataract and a very hard cataract is very bad for a beginner. Both are bad, pecs, small pupil. So choose the best grade to start is grade 2 to grade 3. Know your machine, know your phaco machine. अब कार है, कार चलानी नहीं आती है, कार को पता ही नहीं है कहाँ पे क्लच है, कहाँ पे ब्रेक है. So you don't know how to drive a car. So you need to know your phaco machine, your microscope. You need to know the phaco dynamics. That's beyond my lecture. So you need to know all the complications. The eyes see what the brain knows. So know what the complications you can anticipate at each and every step. And the two most important things which I'll say for the beginners and for everyone, even for me today, do not hesitate to ask for help. Please don't create it a prestige issue. Do not hesitate to ask for help. Number two, whenever required in the benefit of the patient, convert. Do not balm your egos, just convert. So the few tips and tips, so when I was preparing this lecture, I have not put any video in this lecture because phaco for beginners, a simple phaco, no point showing the videos. So I'm just showing the points what my teachers used to draw and tell me when we were doing phaco emulsification training. So the problem is, from what are you converting? Are you converting from ECC to phaco or you are converting from SICS to phaco? I converted from ECC to phaco. That has a very long learning curve. SICS to phaco is 2-3 cases, believe me, you'll be able to do phaco. So incisions, we have 2 side port incisions and the 1 main port incision. So my teacher always used to tell me, when you make a side port incision with a 15-degree side port blade, always keep the blade end, the cutting end up and just enter 2/3 of the incision, the blade into the incision. For the main port incision, you need to have a triplanar incision. So go vertical, then go horizontal, and then go vertical. Some people even do biplanar, but triplanar is very important. Mastering incisions is very important because this is the main reason for the outflow and anterior chamber instability. So ECC fellow has to master incisions much more than a SICS fellow. Staining of anterior capsule is as you do for any other case. Capsular excess. My major learning curve was in capsular excess. When I started doing phaco emulsification, every time my excess was running out. So my trainer, I actually asked him, sir, if I go after doing 20 cases from here, how am I going to do phaco emulsification? So he stood there, and this is the same diagram he drew for me. He said, whatever is your pupil size, you start the initial nick of capsular excess just half of the diameter of the pupil size, because when you are going to lift that flap up, it is again going to go out. If you go more than half, then when you lift your flap up and you start rotating, it's going to run to the equator. So in the beginning, when you start learning capsular excess, the first incision not more than half the pupil size. A pupil size means a dilated. In a beginning, you will take a dilated pupil. A small pupil doesn't work for beginners. So hydrodissection and delineation, very important. This is a step which everybody rushes, but this is a step which creates a lot of problem if not done properly, because this is a step which is going to free the nucleus from the posterior capsule. So give a good spend some time on hydrodissection. Go on all the sides, 3 o'clock, 6 o'clock and 9 o'clock, and give a gush of fluid so that you see a wave of fluid going behind. And ideal hydrodissection would be you lose the red glow. Then is your phaco foot pedal, very important. Beginners know you don't need to learn your phaco pedal on the patient, learn it outside. There are 3 steps, I don't need to elaborate that. But those 3 steps, your ears have to get attuned to the sound of those 3 steps. You should know whether you are in phaco pedal 1, pedal 2 or pedal 3 state. So very important to master this outside. And settings, the phaco settings in the beginner, time, speed is not important, quality is important. Keep your settings low, the vacuum low, the flow rate low, go slow and steady. The trenching, when you do start the nucleus trenching in the beginning, please remain between the capsular excess margins. We do not want that the beginners should, when they start doing a trench, they should eat up the capsular excess margins. So remain between the capsular excess margins and go below and deep and also widen the upper part of the trench so that you can go deeper till you see the red glow. And the best thing, the difficult thing which SICS converter into a phaco feels is how to crack. So that diagram that side just shows with a phaco tip and a chopper, go deep in the groove and then break. If you go deep in the groove and break, it cracks. If you do not go deep in the groove, thinking that there's a posterior capsule, there's no posterior capsule there. There is a bit of nucleus there, there's epinucleus there, so don't really worry. If you do not go deep, then you are actually just creating the nucleus like this. It is not going to break, it is going to go like this. You need to break, you need to go deep. So for the nucleus chopping, you beginners usually do divide and conquer and stop and chop. So for a stop and chop, you do trench, and then you have to do a chop. So you have to embed the nucleus with phaco setting 3. Once you are in the nucleus bed, then you immediately come to phaco setting 2, and then just give it a slight pull towards the center, and with the chopper just divide it. So this step is most of the time not that difficult. Okay, the aspiration for SICS and the ECC trainers. If you are doing a Simcoe cannula training, I would suggest on SICS start using the coaxial or bimanual on SICS. So the best thing is don't give radial pulls, because that actually sometimes give a stress on the zonules. Go in a curved manner that actually collects a lot of cortex, and then give a pull and then aspirate. So IOL implantation is same, hydration of the ports are the same. The main thing for phaco beginners, which my teacher used to tell me, is be aware of your left hand. Phaco is a bimanual technique, and most of the problems are created actually with your chopper in the left hand. You touch the endothelium, you touch the posterior capsule. So be aware of your left hand, and that also you can do outside. So my teacher used to tell me, start brushing with your left hand, start eating with your left hand, start writing small signatures with your left hand. So make your left hand also a bit dominant hand. So my last thing, just believe in yourself. Anybody can do phaco. It is not rocket science, but it needs a lot of practice. So practice, and Rome was not built in a day. And if you look really closely, most of the overnight successes took a long time. Thank you.
It was so wonderful. All my colleagues were saying that it reminds me of our residency, and it also shows how much effort you have put in making this presentation. All were handwritten drawings and beautifully presented. Thank you so much, ma'am. I now request Dr. Manpreet Brar to please come on the stage. She'll be talking on phaco in diabetic retinopathy oblique diabetic macular edema patients.
Hello, yeah. Good afternoon, everybody. And thank you, organizers, and thank you, Dr. Rajvinder, especially for inviting me over. The session is on phacoemulsification, but I'll be drifting away to the retina part of it. The reason being that we are all, people who are here, they're all masters of their phacoemulsification surgeries, but still, there are days when you have done a beautiful job, the surgery looks good, but you end up with an unhappy patient. And the reason for that is that there is something going beyond your lens, and that is what we are talking about, the retina. India being the population, the most number of diabetics being around here, diabetic retinopathy and diabetic macular edema remains one of the commonest reasons for low vision that comes back after the cataract surgery. So that is what I'll be taking you over. So when it comes to diabetic macular edema, you need to understand that as soon as a patient gets a diagnosis of DME, the standard thing that comes into the mind is, okay, so it's going to be around 6.9 injections per year. That means 6 to 8, could be number 10 also. The hospital visits will increase, the cost of the patient will increase, and 25% of them will end up getting into anxiety or depression because of this chronic disease that they will have. And when it comes to diabetic macular edema along with cataract, the situation becomes further worse, And the reason is that the cataract being one of the major causes of visual loss in diabetics, and 20% of all cataract surgeries are performed on patients with diabetes. The risk of developing cataract also increases if you have maintained a very poor metabolic control, and it also increases with your duration. And if you look at it from the retina point of view, diabetic macular edema is one of the main causes of poor visual results after your lens surgery. And diabetic patients who are undergoing phacoemulsification, they appear to have doubling of their DR progression rate at 1 year follow-up. So DME plus cataract together is not a good combination because it causes reduced visual acuity. It also interferes with your adequate examination of the retina, and it also makes your photocoagulation difficult. So from both the sides, from the anterior segment side and from the posterior segment side, this combination is not a good combination to have. So what happens? What are the basic challenges that you face? That there's a worsening of macular edema in 20 to 50% of the patients who are undergoing cataract surgeries. And more importantly, there is progression of their diabetic retinopathy. So if you have a moderate NPDR to begin with, patient undergoes a phacoemulsification or a cataract surgery, whichever way, they will end up by year 1, the diabetic retinopathy risk might further worsen, and they might end up into a proliferative stage. There is more chances of getting into an anterior segment neovascularization, and there are increased intra and postoperative complications. But the question remains that why does it happen, you know? Why? And the answer for that is that the phacoemulsification, whenever we are doing with a foldable IOL, the blood aqueous barrier becomes more severely affected in diabetic patients as compared to the non-diabetic ones. And it has also been reported that the VEGF levels in aqueous humor, if you measure it at day 1, they are higher after a cataract surgery, and it usually takes a month for it to get optimized. So how to approach such patients? Your pre-op workup is the most important part. When to operate, the timing has to be decided carefully, and the choice of procedure varies. Post-op care is equally important. So when it comes to a pre-op, the main important thing is that fundus examination by a comprehensive ophthalmologist or by your retina colleague is a must in all diabetics. And if your media permits, retinal diabetic retinopathy screening should be done before you decide for a cataract surgery. And if you end up being with a very hazy media because your cataract is too dense, I would still suggest that perform a fundus exam to the other eye. That will give you some clues, and ultrasound for the concerned eye before you take any further proceedings. So every patient who ends up with us, we end up performing a baseline color fundus photograph along with an OCT. So this is a prerequisite before we take up the patient for a cataract surgery. This is how a clinic runs over there. So the intervention will depend on the stage. So if you see that your patient has a proliferative disease at the back, the cataract can hold if your media is good enough. So you have to manage the retina first. If you see that there's a diabetic macular edema, but it is not involving the center, again, try to treat the DME first, and the cataract can still wait. If you have a center involving it's bad. So the approach is usually combined, you know. So you have to take the help of your intravitreal injections or your intravitreal steroid implants. And the most important thing is counseling. The expectations should be realistic, and the patient has to be counseled for long-term treatment even after your surgeries. So for DME, the standard line of management will and always remain anti-VEGFs. Dex implants is the second choice. So this is one example. If you end up getting a fovea-threatening diabetic macular edema and your view is pretty good, and seen by the cataract surgeon but referred to a retina specialist before they can take up for surgery, it's better to perform a macular laser. That still holds true in today's generation of anti-VEGFs. Wait for a couple of months, maybe around 3 months, and then you can safely take up the patient for your cataract surgery. If you have early DME and your CFT is around 400, you can always combine your surgery with an anti-VEGF injections. And this is how has been proven by the multiple studies done so far. So this is one example where Dex implants is another thing which we quite commonly use during the procedure of performing a cataract surgery if you end up with a moderate DME. So this is a case that presented in February. It's cataract with moderate NPDR and DME, and that's why the visual was 6/60. So underwent a same-day phaco with a Dex implant, and 2 weeks post-op, the retina also looks good, the anterior segment also looks good, and he's around 6'9" and quite happy. So here, the things don't end here. You need to keep the patient on a follow-up, because you know that the DME might will definitely come back. And so in the next 4 to 6 months, call the patient back and then reevaluate and then take your next step. If you're dealing with an ischemic, then it's very, very important to counsel them accordingly. That, despite the, it's not that you can't perform a cataract surgery, you can, but the expectations of the patient has to be pretty realistic. The timing, the patient's metabolic control has to be good, your macula has to be flat, the DR ideally should not have any active neovascularization before you start taking the patient for a surgery, and the phaco ideally should do a meticulous cortical cleanup, single piece hydrophobic lenses, and try to have the phaco time should be reduced so that there is less inflammation in and around the eye. Post-op care, all these cases, they need follow-ups of around 16 weeks to 1 year. And so you need your retina specialist around when you are taking care of these patients. Nepafenac is also proven to be quite useful in preventing macular edema, which has to be used for at least 3 months after you have performed a cataract surgery on a diabetic. So this is my last slide. So the key to better visual outcomes depends on a pre-op complete retinal evaluation. The decision regarding the timing of surgery, need for pre-op laser, need for pre-op and intra-op injections has to be justified before. The problems associated with the cataract surgery, the choice of lens, the procedure, and the post-cataract surgery management is equally important along with the systemic control. Thank you.
Thank you, ma'am. Sir, any questions from Dr. Manpreet? From the audience? Any questions? Sir? Dr. Dhami, sir.
Hello. It works. Just the basics. Role of NSAIDs preoperatively?
No, sir. Only on day 1, before we post the patient for surgery, day 1, and then post-operatively for 6 weeks to 3 months.
And what kind of NSAID you like to use, the high strength or the normal, I mean say 0.3 or the OD dose or VD dose?
Of what, sir?
NSAID, any NSAID?
So NSAID is 3 times a day.
3 times a day?
Yes, sir.
Right, thank you.
One thing you showed, ma'am, about the role of, special role of robolaser instead of ordinary phaco.
Yeah,
Any significance with that?
So what the phaco surgeons basically prefer is that the timing of surgery and the risk of complications should be minimized when you are dealing with a diabetic patient.
But what has robolaser to do with this?
Probably, I'm not the phaco surgeon, so but I presume my phaco people think that the robolaser works. It will help you lessen your complications.
Probably, if I can imagine, robolaser has a role because diabetic cataract, the lens itself has a morphology which is different in every case. It's different in an immature, it's still different in grade 2, and it's worse when it's grade 3 or grade 4.
Or just to support in a way what you say is that whatever the complications are to happen, suppose it's a case of fluid exfoliation or something like that, and suppose that is supposed to happen, it might be minimized with robolaser. That's the way.
Possibly.
Yes.
Dr. Ashwini, sir, any questions from ma'am? Dr. Sandeep, sir, any discussion? Thank you, ma'am.
Thank you.
So our next speaker is Dr. Punita Garg. She'll be speaking on extended depth of focus IOLs, EDOF IOLs.
Good afternoon, everyone. And special thanks to Dr. Rajvinder. So that's why I'm here. So it's like a homecoming to me. I am also part of Adesh family. So I will be speaking on EDOF IOLs. So as we all know, the earliest example of cataract surgery that dates back to around 3,000 years ago, couching was the procedure of pressing the lens down in the vitreous. So now we have come a long way from the couching to the new generation IOLs. So as we know, Harold Ridley, that he introduced the IOLs, and nowadays foldable IOLs, which require much, very small incision, they are dominating. So with the monofocal IOLs, they target for the clear distant vision, but near vision of the patient is always compromised. This has led to the development of presbyopia correcting IOLs like multifocal IOLs, accommodative IOLs, or EDOF IOLs. So we can tackle the presbyopia either with the monofocal IOLs, with the reading glasses, or with the monovision correction, multifocal IOLs, or accommodative IOLs. So with the monovision correction, visual requirement for the near can be met, but stereopsis is impaired, so the loss of stereopsis is there for the patient. And with the multifocal IOLs, they consist of multiple zones of the lens power that produce more than one focal point, allowing for enhanced vision for both near and far. So various multifocal IOLs, they are the bifocal diffractive IOLs, which create two distinct images for the far and near. Then we have trifocal diffractive IOLs. So compared to the bifocal refractive IOLs, the trifocal IOLs, they improve the intermediate vision also by providing a third focus. Then we have refractive IOLs. So they function by creating the multiple focal points that allow for viewing at all distance, from the distant to near vision. So the multifocal IOLs, they are associated with their own drawbacks like loss of contrast sensitivity mainly, and glare and halos because of scattering of light. And this creates a lot of problem for the patients who are very active and they need to drive at night, and off-axis aberrations are there if the IOL get decentered. Then came the accommodative IOLs. So placement of the accommodative IOLs in the capsular bag that allow it to simulate the natural accommodative process in the eye. So it changes the power in response to the contraction of ciliary muscles. So only the FDA approved accommodative IOL, that is crystal lens, that has a 4.5 mm optic with haptic plates, and that is fixed in the capsular bag. So accommodative IOLs, they have their own advantages and disadvantages. So there is no loss of contrast and glare and halos as seen with multifocal IOLs, but because of capsular contraction and fibrosis, so that can result in the distortion and decentration. And the optic of the accommodative IOL is small, so there are more optical aberrations. So that new technology that now we are entering the era of extended depth of focus, EDOF, or the extended range of vision IOLs. So this is a new technology that has recently emerged in the treatment of presbyopia correcting IOLs. So this is the multifocal, EDOF IOL. So EDOF IOLs, they work by creating a single elongated focal point to enhance the range of vision or the depth of focus, which is desirable in treating the pseudophakic presbyopia. So that's how the EDOF IOLs work. So there is extended focus of vision. So extended line is there instead of a single point. So patient is able to see both the distant and the near, along with the intermediate vision is there. So the ideal EDOF lens, that will cause light to converge on a line when one end of the line being on the retina for the distant vision. So in monofocal lens, when the patient tries to see a near object, there is a circle of blur. But in ideal EDOF lens, when patient is viewing the near object, the other end of the line, that is on the retina. And this ideal case will mean that all the objects from the distant to near vision, they would be in the focus simultaneously on the retina. But to create ideal EDOF lens, it's nearly impossible because of the principle of the physics involved. So for a real EDOF IOL, the concentrating the light into a narrow channel, that will create a good vision over an extended range of the distance. The width of this channel dictates that how sharp the images are, and the length of the channel determines the range of distance the real EDOF IOL would operate. So various technologies to help, complementary technologies that help the EDOF IOL. One is its ash-led design, then the spherical aberration, achromatic technology, and micro monovision. So ash-led design, there is modification of the height, spacing, and profile of the rings. So that helps in gaining the enhanced focus of the vision. So that diffracts the light in a specific way that transmits the light over a range of distance by causing constructive interference, and there is extended depth of focus is there, which provide the high quality of vision to the patient. Since there are no multiple focal points, there are no multiple images which are out of focus and reduced glare and halos which we encounter in a patient with multifocal IOL. Then the spherical aberrations. So generally we prefer aspherical lens, and but with the specific amount of the spherical aberrations that may expand the depth of the focus without significantly compromise the quality of the focus. So there is increase in depth of focus which can reach even up to 2 diopters with a 0.6 micrometer of the spherical aberration. And micromonovision. So if we target the refractive target of the non-accommodative eye to 0.5 to minus 0.75 diopter, so that leads to advantages like the small difference for the distant vision that is well tolerated, that will improve the near vision. It is not associated with the issue of traditional monovisions, so that can be easily reversed with the glasses, and patient is left with a good distant acuity that can meet the driving standards, not only with the both eyes open, but even with the each eye individually. So type of EDOF IOLs, basically we have 3 types of the IOLs: small aperture EDOF IOL, diffractive IOLs, and the enhanced monofocal IOLs. So small aperture IOLs, the light entering the eye is blocked by the small aperture. So here only small cone of the light that enters the eye allowed to pass. So they don't increase the concentration of the light in the EDOF channel, but they instead remove the light which would fall outside the channel. Then we have diffractive. These are the hybrid IOLs, diffractive multifocal EDOF lenses. So they have aspheric anterior surface and posterior diffractive surfaces. So that creates a elongated focal point. So diffractive lenses, they split the light into 2 or more foci to create a elongated focus from the distant to near vision. And then, so this is a new technology, wavefront shaping technology, that is mainly so here light is mainly confined to the EDOF channel. So this X-wave technology is there, which is patented by the Alcon company, used in Acrisoft and the Vivity IOLs. And here the X-wave, so the light waves, as the wavelength propagates, it collapses down, resulting in the wavefront being stretched forward and backward, and that creates an extended focus of a range of focus. Then the other one is enhanced monofocal IOLs, generally seen in Technis Eyehance and the Ray-1 EMV. So they change the geometry of the central optic area, causing a change in power from the center to the periphery, thus increasing the central power of the lens or the elongation of focus by the wavefront modulation effect. So in nutshell, the multifocal IOLs, they are excellent for the multitasking individuals which need clear and near and distant vision without relying on the glasses. So, but they produce some disturbances like halos and glare. And the EDOF IOLs, they are ideal for the patient who require sharp focus for activities like driving, etc., where intermediate and distant vision is crucial. So but they might require some supplemental reading glasses for reading very fine print. So the EDOF IOLs, they have revolutionized the world of presbyopic vision correction. So as the technology is advancing, the future of EDOF lenses that look brighter than ever. Thank you, everyone.
Thank you, ma'am. Sir, any questions for Dr. Punita? Dr. Brad, sir? Dr. Ashwini, sir?
There is a separate type of lens, autofocus pro lens. Have you used or heard about this?
No, sir, I have not used it.
That gives MTF value 72% at all the distances, near, intermediate and distance. No rings, no halos, glares, and patient sees clear vision at near, intermediate and distance.
So that will be even more beneficial.
I have implanted, that's very beneficial. That is designed by some doctors from the south, and that's a very good lens.
I'm using Rayner EDOF lens only.
Okay. Thank you.
I think I'll have a lot to say in my talk. I'll continue.
Thank you.
Thank you, Dr. Panita. Very nice talk. With the increasing range of EDOF lenses, I think the focus of cataract surgery is mainly shifting to EDOF rather than preferring monofocal lenses. Thanks.
Thank you.
So, our next speaker is Dr. P.S. Brad, sir. FACO, My Way.
Good afternoon, ladies and gentlemen. At the outset, I express my gratitude to the management, Dr. Gill and his illustrious son, Dr. Rajvinder, Dr. Ritesh, and all dear friends of this institute. So I'm privileged to be able to speak over here. I'll be talking how I've tried to simplify the process of cataract extraction or phacoemulsification and try to do it in as less a time and as free of complications as possible. So I'll be moving stepwise. There are a few common steps that are to be gone through by everybody while doing phacoemulsification. So first step is corneal incisions. I try to make a pocket incision before the main incision, which is about 3 millimeter, 0.3 mm anterior to the planned site of main incision without entering the anterior chamber. And the length of this corneal pocket is about 0.3 to 0.5 millimeter. Well, this is how I show the pocket incision being made. This is the pocket incision with the right side keratome, and it is 3.3 mm anterior. Now is the main entry. I'm deliberately slow in entering so that I can show now the two incisions are made, pocket incision made, everything is made. So now advantages of this pocket incision is the hydration and better security of the main wound. Hydration of only the edges never ensures complete closure of the wound. Superficial wound is hydrated with the touching of the and without touching the main deeper wound, and that makes it swell and compresses the main tunnel and hydrates its sealing in a better way. See, I'm just hydrating here the tunnel, the pocket incision, and that's it. And the job is done. Now, creation of main tunnel and side port simultaneously helps to hold the globe in a position that side port gentle holding helps light counter traction, AC is better maintained, and more importantly, we can position our hands at a proper angulation with respect to each other, and this time saving as well. And next is staining of the anterior capsule with the trypan blue. We can do this with a 26 or 30 gauge cannula when needle is mounted on 1 mm syringe filled with trypan blue and air is in front. Advantages are it prevents the escape of air during injection and allows selective staining of capsule and avoids excessive buildup of the dye inside and stains much faster because the dye is under pressure of the air, which is injected always prior to it. Now, this is being injected with a 26 gauge needle. We can do it with 23 gauge needle also, which I'm also doing sometimes. In that case, we don't have to make a sideboard entry later on. Now, this same hand, left hand, works as a spatula and holds the globe, and the right hand is making the incisions. Now, job is done. Same way we can do it in case we are not using the needle, we can do it with cannula as well, but air should be in front so that it compresses upon the dye in a better way. Next is capsule rexes. The size should be 5 to 5.5, should be regular, central. You can do it forceps or with capsulotomy needle. And while making the rexes, the care should be taken that how to stay central. This is extension. So this is spiraling out of the rexes I'm showing, how to extend it slowly in case we need to. And we should try to remain equidistant from the iris. Iris is a good landmark. Let's stay equidistant from all sides. That helps it better. Well, this is another capsular axis in a comparatively with a better red glow. But we are trying to remain equidistant from the iris. Iris is a good landmark. And as some already said by one of the speakers, our forceps or the initial tear should be less than half of the total size of the rexes available with us. Now rexes has been done, and then the hydro procedures. It's a must in all cases. Minimal, and very importantly, that's the way I do. I never hold a 2 mm or 5 mm syringe. It's always done with a 1 ml syringe for better control, and lest more amount is injected inside inadvertently. Minimal fluid injection, gentle wave, but it should be complete, and we should always try to express the fluid out from the other side. And hydrodelineation is not usually done by me. It's an unnecessary step and doesn't serve any purpose, and it creates unnecessary epinuclear shell, which in itself is a task to remove, except for posterior polars. Well, nuclear rotation is important, very important rather, but it's usually not required as a separate step in itself. The same hydrocannula, after aggressing the fluid, can help in rotation and assessing and make us assess better whether it's been rotated properly or not. Overzealous rotation in pseudoexfoliates sometimes can lead to complications in the form of maybe some small ZD. And here I'm just trying to show the wave generation, see the wave, and egress it from the opposite side, and with the same hand the job is done, that's it. This is enough. And now is the chopping. I usually do direct chopping, in which we bury with the chopper, with the phaco tip, and the chopper travels all the way. How much chopper has to travel depends upon the consistency, the hardness of the cataract. See, it's done. So this was an equatorial chop, or I also call it a submarine chop. But the same thing can be done with a karate chop also. This is a karate chop. So I just wanted to demonstrate. Well, that's it. Next, this is a softer cataract. I'm trying to show the same thing. And just nudging, this just have to hold. That's it, done. This shouldn't take more time than this if central chopping is done. Well, this was the chopping in a softer nucleus. And after making the parts, we can take the things with higher fluidics, and everything comes. Then we can chop the way we want. That's all. Then is the irrigation and aspiration. I call it IS sweep. Always hold the anterior lip, never hold the posterior lip of the cortex. Posterior lip leads to a lot of remnants on the PC. Always try to hold the anterior lip of the cortex and try to take 12 o'clock cortex first of all, because that is the point when the bag is already well made. If you try to take 12 o'clock cortex at the end, that by the time the bag is collapsed, and we may find it hard to grab the cortex, and sometimes the PC also tries to come in between. Well, this is the polishing. There are many methods. I'm just trying to show one here, only here. This is manual polishing, but the hydro polishing that I demonstrated yesterday also pretty well, and almost devoid of any complications or inadvertent PC tear. Well, this is a full cataract I'm trying to show in steps. The staining is done. Here is the intumescent cataract, and we must deflate it before we start, and so that we are sure that no complication is done. So needle is inserted from the right side, and we stab it in, and just suck it out immediately. See, so the fluid comes out into the needle, and the lens is decompressed. Now we can proceed with the phaco the way we want, and Rex is in control signs. The chances of Argentinian coming are almost nullified. So, same way, rest is same. Only this, we should try to debulk with the loose anterior capsule, and going to the periphery. See, both the instruments travel. Sometimes when the cataract is very soft, only the left hand needs to travel, and if it is hard, then both hands travel equally good, equally well. So this is again a karate job. This is a different case. I think that's all, my friends. Thank you so much. Any questions, sir?
Questions to Dr. Bharat, sir? Sir, if I may ask one question, sir, you were using two different kinds of choppers. The last surgery you show, the chopper was a sharp chopper, the tip was a sharp one. The other ones which you showed were an inner cutting chopper with the tip being blunt. So will you please guide us in which case would you use that chopper, and how is it more beneficial to use these
Usually, when the consistency is hard or length is harder, beyond 3 or 4, I use sharp tip chopper. And when it is 3, most of the times we are able to manage with blunt chopper with inner cutting edge. But whenever it is hard or we want to do with more of karate chopping, then we need to have a sharper tip to penetrate the mass of the lens, mass of the cataract for ease of making it karate chop.
The IT people, could you please show those two videos for the benefit of the residents, which one is a sharp chopper and which one is a inner cutting chopper, so that the residents would be more benefiting from that particular thing?
Can I add meantime a line? Can I pinch in?
Yeah.
See, believe me, these choppers were made when we were not expert. Basically, you should understand that it's attractional forces where you apply. Separation, holding. And years, myself and Dr. Brada have learned a lot from him. It was years when we presented in US that it's just like fork and knife using on your table. It's not the force, it's not the cut, it's not the sharpness, it's how you separate with your knife your bread. That's all.
So this is a sharp chopper, sir. Sir, will you please describe this chopper?
This is a, let me see here. This is a sharp tip chopper.
Yeah.
And let me go to the next case. It's a very sharp tip. This is overused. The tip is not that sharp as it was to start with. To start with, it was able to penetrate even the brunis and cataracts also.
So this one is the another chopper.
And this is another chopper. Just let me hold it.
So this is a little softer cataract, probably, sir.
This is a sharp, very blunt chopper, and I've got another chopper with almost like a ball at the tip, so that it cannot puncture no matter what. And all the same, the cutting edge is very sharp, so that when you drag towards you, it just keeps on just like cheese wiring, it comes through.
So sir is mentioning about the horizontal chop, so that when he goes beyond the equator and the ball does not hit the posterior capsule. Am I correct, sir?
Yes, sir.
Thank you, sir.
Thank you.
Any questions for Brad, sir, from the audience?
Thank you, sir.
Thank you so much, sir. Dr. Dhami, sir.
Hello, good afternoon, everyone. At the onset, I thank Dr. Rajvinder, Team Adesh, for creating such an academic atmosphere on a Sunday which seems to be most useful. You have seen Dr. Bharat's surgery, excellent surgery. You learned a lot about IOLs from Dr. Puneet's talk, basics from Dr. Gurvinder's talk. What happens once you have done an excellent surgery? Why isn't the patient happy? Why does he return to you? I am not seeing. I have paid you so much. Then what have you missed? I'm going to put forward to you something which we miss. Well, what we miss is only what we think when you got to get your lens implanted in your eye or your friends or your relatives. You think so many times, what is that? I have no financial disclosures because I'll have to name a couple of IOLs. What we miss is the first thing, that there are 3 refracting surfaces in the eye, the cornea: let's see what we miss in the cornea, the corneal aberrations. Why we miss them? Because 90% don't need to be talked about. These are lower order aberrations, namely defocus, astigmatism, the spectacle correction. What we never think about is the higher order aberrations, the sphericals, the comas, the trefoils. You never think what the patient needs. You are just putting an IOL given to you or the cost given to you. Then, have you understood the asphericity of the cornea? Cornea is an aspheric surface which is going to reflect light in various ways from the apex to the periphery. We have never thought of it. And who are people who can read well even at the age of 50 and who can't read at the age of 35 too? So this is how the asphericity of the cornea plays a role. We have prolate corneas, the lucky ones. We have oblate corneas, the unlucky ones, and in between, the most lucky ones who say, I didn't develop presbyopia before the age of 50s. Then, what are these? There are some toxic aberrations, some acceptable. And the human cornea has measurable normal aberrations of plus 0.27. Please note this. These have to be neutralized by your IOL, which you hardly take into consideration. Yes, my earlier colleague was talking about Rayner. Rayner is the only lens which provides you positive spherical aberrations. All other lenses give you negative asphericity of various value. Some give zero asphericity. Then why don't you know about asphericity? Why shouldn't you calculate for each IOL? We all have in our clinics something known as topography or pentacam. It is very important to know what are the, I don't know, cursor is not coming. Anyway, what are the higher order aberrations of that cornea in that particular patient at that age? Are they normal, low, or high? That will depend on how happy the patient is. Some predictable values, comas in between 0.12 to 0.7, spherical aberrations less than minus 0.5, total aberrations less than 0.8. This is a toxic level. No cutoff values affected by age, affected by population, measuring devices, study design, and your mood to think of them. What are tolerable higher order aberrations? Normal, anything between minus 0.035. Suspected, anything below 5 or above 5. Mind you, these are the people, if you are not taken into consideration, will land problems when you put up multifocal IOLs, EDOFs, or whatever you call as wavefront optimized IOLs. Then let's make a final conclusion. If the pupil is small, avoid all this. We are lucky Indians who never consider this because our pupil is never more than 2.5 or 3. Patient who drive, avoid hybrid EDOFs because their pupils tend to dilate and these higher order aberrations are going to trouble him. Patients who are interested in near vision, these need more negative asphericity. You have different IOLs, I don't name them, but they are benefited with them. Then we have second test, eye trace, something I missed for years. It will tell you everything in the cornea. And if I can, it will even tell you what to choose in a lens, whether a premium IOL, whether a monofocal IOL, or aspheric IOL. Why? It tells you the aberrations in the cornea, the aberrations caused in the lens, and the retinal higher order aberrations. Why shouldn't we have it? We ought to do in every case. Then it makes virtually a table for you to decide. Perform eye trace, Meyer's angle kappa, high angle kappa, forget about multifocals, and go for monofocal directly. It gives you lower order of corneal aberrations, you can go for a choice of your lens. Analyzes corneal optical quality using Chang analysis, that how much cornea is going to obstruct your vision, then the only choice is monofocal. If it gives you the toricity of the cornea, and the only choice is trifocal. So where the hell is the company's choice? Put this oil, put this oil. You got to look what you are using. Finally, normal high road operations are minus 0.3. Depth of focus increases when you increase them. If you want image quality, you got to neutralize these, and these are monofocals what are doing. Then, what does a patient expect in cataract surgery? Mind you, you have seen Dr. Brad's excellent surgery. I have learned from him for the last 35 years. Every step we discussed, and those people who don't discuss don't learn. Every day is learning. Believe in yourself. Thank you, Dr. Brad. Let's see what the patient expects. For my considerations, I take the corneal health, corneal aberrations, patient's demand, good reading. Will he tolerate halos? Will he tolerate glare? Yes, you can go for multifocal. Otherwise, forget it. In first line of question, the patient will tell you what he needs. If he needs quality of light, you will have to give him multifocal. Remember, the photons, the amount of light entering the cornea, entering the pupil is the same. Only thing you are changing is the way it is going to enter. That is what my colleague talked before me. Then patient selection, accurate biometry, and finally what Dr. Brad told you is centered rexes. I'll come to that. I need little more time, madam. Patient's knowledge. If he knows about the IL, don't teach him. If he knows little knowledge, you can tell him, you change to this. If he has no knowledge, you are lucky. You can command. And then this is for the optometrist. We have this put up in our OPD. The cataract is diagnosed, optical biometry, corneal topography. Corneal topography, underline it. Note the higher order aberrations. The corneal aberrations, depth of cornea you need. And important, scotopic people, angle alpha. Forget about what you are talking about, multifocals, trifocals. So, corneal cylinder, the optometrist should be taught first line. Is it matching with your topography? If it is not matching, check it twice. Give a lubricating drop. You might be having a dry eye. Once it matches, you decide for a toric lens. And don't forget, my speaker before me said retinal examination, the most important. Don't classify yourself as surgeon before you are told to operate by your VR surgeon. Well, these are already talked about the profession of the patient, driving, demanding, and retired people. They are the people most fit for trifocals. Patient satisfaction, give him 5 minutes extra. Talk to him. He will tell you what he needs. You needn't decide. Preoperative assessment, very important. On slit lamp, first light you impact on the slit lamp will tell you about the tear film, the tear levels, the SPKs. Please consider them most important. Type of cataract, like people mean, Dr. Brad, only come to know when they operate, when they dilate on the operative microscope. That gives us a decision. Ocular comorbidities, understand the patient, whether it's diabetic, or tell all patient, all of your flooring staff moving in the OPD to ask the patient. Many a time when you miss it, but they know it. That patient is diabetic, hypertensive, he has suffered this, he has got multiple injections from the vitreoretinal surgeon. You might be landing into problems. Red flags only to be taught to the optometrist. All this just discussed. I'm going to skip this because you are. So finally, this is another chart in our OPD. All trifocal, patient demanding trifocal, show him what are glares and what is halos. Patient require crisp, mainu bahut changa dekhna hai. Forget about anything beyond it off. and every individual needs a different IOL. No one IOL is one for everything. This again is a sign, logo put in our clinic. You have to keep into mind of your staff moving around that these are the patient you got to tell me. Many times you forget that patient got an RK done so many years back. He got a LASIK done couple of years back. Mind you, these are the worst patients because when he got his LASIK done, he had a crisp vision. And when you are going to do cataract now, he is going to have a vision which may not be satisfactory to him. And this part probably was discussed by Dr. Puneet. What is refractive, what is diffractive, and what is a wavefront? And what is a focus, bi and monofocal, the ideal focus you need, but the ideal focus is you need to decide. So EDOF is a lens for all ages, quality of vision is good, loss of contrast sensitivity is good, light going into eye is good, active lifestyle, frequent drivers can have it, anyone can use it. It might be labeled as lens number 1. This is a complex slide, tells you what all company people are going to tell you, what my IOL is bothered about. Please, when you select an IOL, try to open the box, read all the documents and the fine prints. They will tell you what you need not to do. And this slide was already presented. And this was presented too. I have little colored. Light is one photon. You have to use it carefully. How you use it is your choice. And that makes the patient happy and happier surgeon, and you don't get an unhappy patient. That's the shaping in a wavefront wavity IOL. It gives you a good monogram. Again, mind you, same light is projected and changed. And that's the quality of the IOL. And to understand various IOLs, this is a good IOL. Has no rings, no diffractive. You got to tell the patient. How I tell the patient? In my OPD, I have a mirror which has clear, oblique, and non-clear opaque lines. We tell the patient this is how you will see through a multifocal. If he agrees, you are lucky. And finally, understand the steps Dr. Broad told you. All these IOLs need perfect centering. Probably here Mrs. Broad was telling about the robotic surgery. Any misalignment, even by 5 degrees tilt, will spoil your show. Technice absorbs a little, accuracy of BVD absorbs maximum, and your monofocal adopts maximum. Who's happy when you give a patient monofocal or a toric lens?
Let's take a closer look at the mechanism of action for the Vivity IOL to see how this lens works.
But important to understand.
The Vivity IOL uses a next-generation optical principle called wavefront shaping, which stretches and shifts the light to create a continuous extended focal range, instead of splitting or refracting the light to create multiple focal points. This is the first time ever that wavefront shaping optical principle has been used in IOL technology, and Vivity is the first and only IOL to use this technology. The wavefront shaping technology of the Vivity IOL is called X-Wave and is proprietary to Alcon. The patented X-Wave technology uses 2 surface transition elements that work simultaneously to stretch and shift the light entering the eye, producing a continuous extended focal range of vision from distance to functional near, with a clinically proven exceptionally low rate of visual disturbances. Looking at a magnified view of the Vivity IOL, you can clearly see the 2 surface transition.
So take-home message is, please understand your patient. The price of IOL doesn't matter. Quality matters. Patient, what he wants matters. Understanding of yourself, of the optics, of the cornea, of the lens, and the retina are important before you decide and jump onto it. And do not forget the tear film. Once you put a patient on slit lamp, first look at the tear film level and tear film breaker time. Can convert. So take-home message is good solution. EDOF is a good solution. Monovision is the best. Higher patient satisfaction, and you are a best surgeon. Thank you. And to comment, I always have this slide. I never forget Cinderella's story. only one shoe will fit one person. So one lens, the right lens, right patient, right expectation. Don't forget 3 hours. One shoe, only one for Cinderella and one for your patient. Thank you. And one second.
Yeah, sure.
One line, you see, it is not the canvas. It is the artist who paints. The photograph you see with me is Dr. Maskett. I went to him in 2010. I thought there's not a better surgeon than him. After 20 years, I came to know on a discussion table what IL should I have in my eyes. I was looking for. And at the end of discussion, he told me I was the most unlucky person, operated at the age of 46, with a 3-piece IOL and ECC was done. Never forget any surgery is bad or good. Never forget the IOL is going to give you the best. You are the best and you are the artist. Thank you.
Thank you, sir, for your kind words. Questions to Dr. Dhami, sir.
Thank you very much, Dr. Dhami, for a wonderful, elucidative talk on different parameters, patient expectations, types of lenses, and role of ray tracing. I just want to ask you something, just out of my little experience with ray tracing. I also do ray tracings in all cases, no matter what. But I have seen patients with angle alpha more than 5. In those who insisted, I have put multifocal IOLs, and those who insisted, and I put, and they are quite happy. They didn't complain about it, despite their angle being higher than despite their angle showing the red flags for their ability to get multifocals, but they were happy.
Yes. First thing, we are lucky. We have pupils which run between 2, 3, 5 and 5 plus. So you are lucky when the IOL works, and it's useless when it's working maximum. That's when the pupil is 2.3 and 3. Because this we did in refractive surgery also. Yes, now this angle alpha, angle kappa are being overlooked by some company because they modulate their IOL on the surface modification with these spherical aberrations. If I'm allowed, I'll name the lens. It's a European lens which creates negative and positive spherical aberrations on the surface of the lens. Even J&J is coming with the same lens, then this angle alpha, angle kappa will be out of question.
Thank you, sir.
So now I welcome Dr. G.S. Barad, sir, for his talk.
Thank you very much. At the outset, I thank the society as well as the Adesh Institute and Dr. Rajvinder in particular for having me here. I'll just take you through some tricky situations and what we need to do, and you will also see some of the things which I shouldn't have done. So I'll just take you through some videos. This is a pseudo exfoliation case, and the pupil is kind of marginal, not very small. This kind of a case should not give too much trouble to an experienced surgeon. The two things you see in pseudo exfoliation is, one thing is that the pupil is small, and the other thing is that the lens may not be that stable. So what you're looking at is a CCC which is large enough. You don't want to do a small CCC in a pseudo exfoliation patient. And you also saw me doing the CCC with a slightly less than inflated anterior chamber. Should have probably had more viscoelastic in the anterior chamber. And the next case, the cataract is slightly harder. Can we have the video moving, please? Need to go back a little. So, okay, if you can start this here. Okay, the key to successful phaco here is the rhexis. The rhexis needs to be large enough. Just because the pupil is small doesn't mean the rhexis needs to be small. If you can manage those things without putting a dilating device, that is fine. But make sure you don't end up with a complication So whatever armamentarium you have with you, you use it for patient safety, and if you are comfortable doing this, then it is fine. The rhexis needs to be at least 4.5 millimeter in size and bigger than the pupil in some of these cases, and a central chop. So you can use a higher viscosity viscoelastic agent to give you a better mydriasis when you do the CCC. But if you do a central chop and the rhexis is large enough, then you can actually do most of these cases without a dilating device. But then again, if you're not comfortable, please go ahead and use something, whether it's an iris hook or a ring. And another case which is slightly harder than the previous one, an intumescent cataract, and you see a hyalinized kind of membrane in the pupil. So I've gone ahead and stretched it a little because these cases, the retina guy may also need a slightly bigger pupil to examine the fundus. For all my intumescent cataracts, I love the two-staged rhexis, that making a small rhexis, then aspirating a little bit of that cortex to reduce the intralenticular pressure, and then going in, giving a nick, and completing the rhexis. This case a little harder than the previous one, so a small trench. Normally I would do a direct chop, but the harder the nucleus, I would err towards a little bit of debulking of the middle. And you need to concentrate on the first crack if you are going to do these cases without a dilating device. Because if you end up with a bowl, you are going to be in big trouble. But you can always go in and put devices like iris hooks or rings even at a later stage. A cataract which is harder than the previous ones. You see that central dark brown kind of sheen you see there. Again, the rhexis needs to be large enough. Do not convert a small pupil into a small rhexis phaco, because a small rhexis is going to give you big trouble through every step of surgery. So the first thing is debulk the middle, hold the nucleus, don't be in a hurry, make sure that the first crack is achieved. You don't want to keep on bowling out these nuclei because the trouble and the grade of difficulty will keep on increasing. The harder the cataract, you want to make smaller and smaller fragments because you don't want to bring out large fragments into the antechamber. And also during the procedure, you can always come out, coat the endothelium a little bit more with viscoelastic and then go in again. IA, again, if you are not very comfortable with a coaxial IA, bimanual IA may give you more control if you are dealing with some of these situations. I'll just take you through a couple of subluxated lenses. This is a 180-degree subluxation with a white kind of intumescent cataract. So you stain the capsule, make a rhexis as central and as large enough as is safe, and then you can support the rhexis with capsular hooks or these iris hooks. This is a very old video. One thing I would say here is never stretch it as much as you see here, because there is a risk you will tear that CCC. The other thing is you have to time the insertion of a CTR. So look here what happens. Look at that. So I've held everything with the phaco tip. The only saving grace is this is a very old phaco tip. I'm working in a government hospital and it is very blunt and I get away with it. So I remove the last fragment and then put viscoelastic and then put in the CTR. The CTR insertion should have been much earlier. So you need to insert the CTR as early as you can and as late as you should. So you want to support the capsular bag in time. So when the nuclei are very hard, the bulk in the capsular bag is quite a bit and it may be hard to put in a CTR right up front. So there's a lot of, there's not a lot of space there. So there you can actually debulk a little bit of the nucleus and then put in the CTR. The CTR, obviously, the open end is opposite to the area of dehiscence so that the maximum convexity of the CTR supports the dehiscence.